Okay, good afternoon.
Good afternoon po, Doc.
Good afternoon po, Doc.
Okay, complete na tayo. Erwin, Ronowell, Monina, Francis, and Abby. Okay, so for this afternoon, we will be talking about tuberculosis. Okay, sino ang ay wait lang. Enabled ba ang share? Wait lang. Hindi pa. Sige, you could share your screen, whoever is tasked to share. Okay, so recently, one of tuberculosis would also be one of who has had changes as far as management and guidelines would be concerned. One, and with the prevailing pandemic, these existing diseases that are very much prevalent, Dr. San Luis, with the pandemic, these existing diseases that are very prevalent have kind of taken a backseat. But remember, as public health physicians and advocates, we should not forget, despite the coronavirus, that there are other disease entities such as tuberculosis still existent within our midst. Okay? So, okay, welcome Dr. San Luis, welcome Dr. Navarro. We will start with their reporting already on tuberculosis.
Hello po.
Okay,
Good
you may
afternoon
start.
po. Good afternoon po. Today we will be reporting about the National Tuberculosis Control Program of 2020. Tuberculosis is an infectious disease caused by the bacteria called Mycobacterium tuberculosis. It is transmitted from a TB patient to another person through coughing, sneezing, and spitting. According to the Philippine Statistics Authority in 2017, respiratory tuberculosis ranked 8th among the 10 leading causes of death in the Philippines. In 2019, the Philippines had the highest TB incidence in Asia, with 554 cases per 100,000 people, according to the World Health Organization. 74 Filipinos die of TB every day and is among the top 10 causes of death in the country. From January to March 2020, the National Tuberculosis Control Program of the DOH recorded a total of 88,662 new and relapsed TB cases, declining steeply by almost 20% between February from 30,728 and March 24,782 cases. This is due to the direct effect of COVID-19 pandemic, as the quarantine had extremely affected and limited the health-seeking behaviors of Filipinos. For the screening of tuberculosis, for the definition of terms, systemic screening of active TB refers to the systemic identification of presumptive TB in a predetermined target group using examinations or other procedures that can be applied rapidly. This can be divided into three. For the first one is the active case finding, or ACF. It is a systematic screening implemented outside health facilities, such as for high-risk populations or settings. In this case, chest X-ray is brought to the community. The second one is intensified case finding, which is a systematic screening in health facilities among all consults. This is also done using chest X-ray screening. For the third one, which is enhanced case finding, or ECF, it is systematic screening in the community using symptom screening, which utilizes house-to-house visits by community workers. For the second one, which is presumptive pulmonary tuberculosis, it refers to any person having 2 weeks or longer of any of the following, such as cough, unexplained fever, unexplained weight loss, and night sweats, or a chest X-ray finding suggestive of TB. For presumptive extrapulmonary tuberculosis, it refers to anyone having signs and symptoms specific to the suspected extrapulmonary site. This has with or without general constitutional signs and symptoms such as unexplained fever or weight loss, night sweats, fatigue, and loss of appetite. For symptoms-based screening, it refers to screening using any of the four cardinal TB signs and symptoms, such as at least 2 weeks of duration of cough, unexplained fever, unexplained weight loss, and night sweats. Screening by chest X-ray, it refers to using chest X-ray to identify presumptive pulmonary TB, which will manifest with common abnormalities that are suggestive of pulmonary tuberculosis. For primary screening tool, this refers to the test or tool that is used initially to detect presumptive TB in the systematic screening of TB. This could use either a symptom-based or a chest X-ray. Health facility with TB services. This provides the entire spectrum of TB services in accordance with the policies and guidelines of the National Tuberculosis Control Program and the Department of Health. This refers to directly observed treatment, short course, or DOTS facility. Close contact. Close contact is a person who shared an enclosed space, such as the household, a social gathering place, workplace, or facility, for extended periods within the day with the index case during the 3 months before diagnosis of TB. Index case. This refers to the patient initially identified TB case of any age in a specific household or any comparable setting in which others may have been exposed. Children. This refers to any person who is less than 15 years old. For the systematic screening in facilities, shall be done for all clients visiting the facility of reason for consult. If the patient consults due to any of the following four cardinal signs and symptoms, such as at least 2 weeks of cough, unexplained fever, unexplained weight loss, and night sweats, simply follow the guidelines to be discussed in the following slides. If the patient consults for any other reasons, also ask for the four cardinal signs and symptoms as stated in the following slides. For the systematic screening of pulmonary primary tuberculosis in adults of more than or equal to 15 years old with unknown HIV infection status in health facilities, we should ask all patients consulting the health facility if they have the following cardinal signs and symptoms that are lasting for greater than or equal to 2 weeks: cough, unexplained fever, unexplained weight loss, and night sweat. If any of the above symptoms are present for at least 2 weeks, we can identify the patient as presumptive TB. For those who do not have any of the cardinal signs and symptoms or experience it for less than 2 weeks, we can offer chest X-ray screening if one has not been conducted in the past year. A chest X-ray PA upright view should be requested, and previous chest X-rays should be brought for comparison. For pregnant women, we can get a written consent. We can take a written consent, and abdominal protective shield shall be used by the X-ray facility. If a chest X-ray is not available and these high-risk patients have signs and symptoms lasting less than 2 weeks, the physician may decide whether to consider the patient a presumptive TB case. All patients with chest X-ray findings suggestive of TB should be identified as presumptive TB. Screening by chest X-ray may be done once a year. For any persons living with HIV or PLHIV, screening by both chest X-ray and symptoms should be done at the time of diagnosis of HIV or AIDS and annually thereafter. Symptom-based screening should be done at every visit. We should take note the signs and symptoms of persons living with HIV, such as cough, unexplained fever, unexplained weight loss, and night sweats. And this can be of any duration, not necessarily 2 weeks. In the presence of one or more TB signs and symptoms and/or chest X-ray suggestive of TB, identify the patient as presumptive TB in persons living with HIV. For the systematic screening of pulmonary primary tuberculosis in children or patients less than 15 years old, we have to identify as presumptive TB if the child has at least one of the three main signs and symptoms suggestive of TB: coughing, wheezing of 2 weeks or more, especially if unexplained, unexplained fever of 2 weeks or more, unexplained weight loss or failure to thrive not responding to nutrition therapy. Second, we can ask if the child is a close contact of a known TB case. If the child is a contact, the presence of fatigue, reduced playfulness, decreased activity, not eating well, or anorexia that lasted for 2 weeks or more should be considered and identify them as presumptive TB. If the child already has a chest X-ray, we have to review the results. If the chest X-ray findings are suggestive of pulmonary tuberculosis, we can identify the patient as presumptive TB. Screening by chest X-ray is not routinely recommended for children except for TB household contacts who are 5 years old and above. For all PTB identify, we have to ask our patients about their previous history of treatment and exposure to a TB case to determine the risk for drug-resistant tuberculosis. We also, for the systematic screening for extrapulmonary TB, first we have to note any of the following to identify presumptive extrapulmonary TB. Gibbous deformity, especially of recent onset resulting from vertebral TB, non-painful enlarged cervical lymphadenopathy with or without fistula formation, neck stiffness or nuchal rigidity, and/or drowsiness suggestive of meningitis with a subacute onset or raised intracranial pressure, pleural effusion, pericardial effusion, distended abdomen, such as a big liver and spleen with ascites, non-painful enlarged joint, signs of tuberculin hypersensitivity such as stemnular conjunctivitis and erythema nodosum. Second, for all presumptive TB identify, we have to ask our patients about their previous history of treatment and exposure to TB cases to determine the risk for drug-resistant tuberculosis. For the systematic screening of pulmonary tuberculosis in targeted community, workplace, and congregate settings, screening using chest X-ray for all, regardless of TB signs and symptoms, shall be conducted annually. This is specifically for adults ages 15 years old and above. For children, only symptom screening as described is recommended. All patients with chest X-ray findings suggestive of tuberculosis should be identified as presumptive TB. Sputum should be collected for an expert MTB RIF test. Healthcare workers are considered high-risk groups for TB because of occupational exposure. In this context, healthcare workers include all those present in the health facility, whether medical, paramedical, or ancillary staff. These include those who provide janitorial, logistics, maintenance, and ambulance services. Symptom surveillance shall be implemented in all health facilities. All health workers with any of the four cardinal signs and symptoms, such as 2 weeks of any cough, unexplained fever, unexplained weight loss, or night sweats, should be identified as presumptive TB. Baseline chest X-ray screening followed by annual chest X-ray shall be done for all healthcare workers. Those with findings suggestive of tuberculosis or with progression of lesions compared to a previous chest X-ray shall be identified as presumptive TB. For the diagnosis of tuberculosis, for the definition of terms, active TB disease is defined as a presumptive TB case that is either bacteriologically confirmed or clinically diagnosed by the attending physician. Pulmonary TB is a case of tuberculosis involving the lung parenchyma. A patient with both pulmonary and extrapulmonary tuberculosis should be classified as a case of pulmonary TB. Extrapulmonary TB or EPTB is a case of tuberculosis involving organs other than the lungs, such as the larynx, pleura, lymph nodes, abdomen, genitourinary tract, skin, joints and bones, and meninges. Bacteriologically confirmed TB or BCTB This refers to a patient from whom a biological specimen, either sputum or non-sputum sample, is positive for TB by smear microscopy, culture, or diagnostic test. This includes expert MTB or RIF, line probe assay for TB, and TB lamp. Clinically diagnosed TB or CDTB, this refers to a patient for which the criterion for bacteriological confirmation is not fulfilled, but diagnosis is made by the attending physicians on the basis of clinical findings, X-ray abnormalities, suggestive histology, and or other biochemistry or imaging tests. New, this refers to a patient who has never had treatment for TB or has taken anti-TB drugs for less than 1 month. Preventive treatment is not considered as previous TB treatment. Previously treated for TB, this is a patient who has received 1 month or more of anti-TB drugs in the past. This is also referred as retreatment. High risk for multi-drug resistant tuberculosis or MDR-TB. This is a previously treated for TB patient. New TB cases that are contacts of confirmed DRTB cases or a non-converter among patients on drug-susceptible TB regimens. Rifampicin-resistant TB or RRTB. These are patients who are resistant to rifampicin, detected using phenotypic or genotypic methods, with or without resistance to other anti-TB drugs. It includes any resistance to rifampicin, whether monoresistance, multi-drug resistance, polydrug resistance, or extensive drug resistance. Turnaround time or TAT, this is the time from collection of the first sputum sample to initiation of treatment for TB. This is SRI turnaround time is 5 working days. This is also referred to as program TAT. Expert MTB or RIF is interpreted based on the table below. The notation T, this refers to Mycobacterium tuberculosis detected, rifampicin resistance not detected. RR, this refers to Mycobacterium tuberculosis detected, rifampicin resistance detected. TI, Mycobacterium tuberculosis detected, rifampicin resistance indeterminate. N, MTB not detected, and I, invalid, no result or error. For smear microscopy results and interpretation, a positive result would show that at least one sputum smear is positive for AFD. This is for plus N, 1 plus, 2 plus, or 3 plus. On the decision and diagnosis based on laboratory results, if sputum or non-sputum specimen tested by expert MTB, RIF, SM, or smear microscopy or TB lamp shows Mycobacterium tuberculosis detected or positive result, we can classify the patient as bacteriologically confirmed pulmonary tuberculosis or extrapulmonary tuberculosis. For patients with expert result MTB without rifampicin resistance, we can classify the patient as drug susceptible TB or DSTB. For MDR-TB risk groups, retreatment, contact of DRTB, a non-converter of DSTB regimen with expert result of MTB detected with rifampicin resistance, we can classify the patient as drug-resistant TB or DRTB. For those who are at low risk of MDR-TB, such as new TB cases who are not DRTB contacts, but with an expert result of MTB detected with rifampicin resistance, the patient can be classified as bacteriologically confirmed TB or BCTB, but we have to recollect a fresh sputum sample for repeat the expert MTB-RIF test and follow the second result on rifampicin resistance for the retreatment decision. For invalid, error, or indeterminate results, we have to recollect a fresh sputum sample and repeat the expert MTB-RIF test and follow the second test result for the retreatment decision. For smear microscopy or TB lamp testing, If it was done and it tested positive, yet the expert does not detect MTB, we can consider the patient as bacteriologically confirmed drug susceptible TB. On the For patients who are at least 15 years old with negative expert MTB-RIF, smear microscopy or TB lamp results, or it wasn't done, we have to retrieve the chest X-ray results or refer the patient for chest X-ray if not yet done. A chest X-ray PA upright should be requested for adults. If the chest X-ray indicates shadows in the lung fields consistent with pulmonary disease, a course of broad spectrum antibiotics without anti-TB activity may be prescribed. If signs and symptoms suggestive of TB are not resolved after antibiotic treatment, the attending physician will use best clinical judgment to decide whether to treat for active TB. If the physician decides to treat as active TB, we can classify the patient as clinically diagnosed PTB. For persons living with HIV, TB is not immediately ruled out, especially if symptoms are present. We can evaluate the clinical response after general antibiotic treatment. If clinical worsening or no improvement, TB is likely. If there is clinical improvement, TB is unlikely, but it is not ruled out, especially if the person living with HIV is seriously ill or have CD4 count less than or equal to 100 cells microliter. Conduct additional investigations or discuss with the physician managing the person living with HIV. For patients below 15 years old with negative expert MTB-RIF, spear microscopy results, or if those tests are not yet done, but the patient has persistent signs and symptoms, we can retrieve the chest X-ray results or refer the patient for a chest X-ray if not yet done. A chest X-ray, PA upright, and lateral view should be requested. For children who cannot stand, request for a chest X-ray anteroposterior and lateral view. If the chest X-ray finding is strongly suggestive of TB based on the following, we can classify as clinically diagnosed TB. These are the following criteria. Markedly enlarged unequal hilar lymph gland greater than 2 centimeters in size with or without opacification, miliary mottling, large pleural effusion greater than or equal to 1/3 of pleural cavity, usually common in children greater than 5 years old, apical opacification with cavitation. Um, there may be also other chest X-ray findings that are likely suggestive of TB, or such as atelectasis, consolidation, reticular or nodular infiltrates, and pericardial effusion.
Children
The specific
um, apical opacification with cavitation. Um,
Oh, nangyari.
Hello po.
Yes, go ahead.
Okay po. Sorry po. We as physicians should exercise our best clinical judgment in correlation with history and exposure and clinical signs and symptoms. These are the chest X-ray findings strongly suggestive of PTB in children and adolescents. For children less than 10 years of age with persistent fever, weight loss, cough, and irritability, we can find on chest X-ray right hilar lymphadenopathy, chronic pneumonia, or miliary pattern. For children aged 10 to 18 years of age with persistent fever, adynamia, and bloody expectoration, we can see on chest X-ray pulmonary cavitations and pleural effusions. If the chest X-ray finding is normal or uncertain and the child is in stable condition, we can follow up the child in 2 weeks. We can also consider giving 1 week of broad spectrum antibiotics if we have not yet given it before. If the child still has persistent signs and symptoms during follow-up, we can classify the patient as clinically diagnosed tuberculosis if a contact of a known TB case. If not a contact of a TB case, we can perform TST. If TST is positive, we may classify the patient as clinically diagnosed TB. If TST is negative or not available, even if clinical signs and symptoms remain unresolved, it is less likely to be tuberculosis. Hence, we can refer our patient to a specialist center for further investigation and management. When referral to a specialist center cannot be made, the decision to clinically diagnose and treat TB can be made by us physicians if the clinical condition is unstable, such as having severe respiratory signs and symptoms, or if the child has other TB risk factors. If the patient is clinically stable and has no other risk factors, we can follow up our patient in 2 weeks or 1 month. Extrapulmonary tuberculosis can be confirmed bacteriologically using expert MTB-RIF. For presumptive EPTB cases where it is not possible to get body fluid or tissue sample, we can give an antibiotic trial and follow up after 1 to 2 weeks. EPTB can be assessed as clinically diagnosed TB by the health facility physician based on signs and symptoms, imaging studies, histology, or other laboratory tests. As necessary, we can refer the patient for presumptive EPTB to health facilities capable of performing appropriate diagnostic procedures.
For the treatment of tuberculosis, next please. So, case holding is the set of procedures that begins at diagnosis and continues to initiation of treatment and then throughout the treatment duration. The medical management consists of 1. Assignment of the appropriate treatment regimen, 2. Monitoring of treatment response, and 3. Monitoring and management of adverse events. Next, please. For the definition of terms, TB disease registration group refers to the classification of TB cases based on history of previous treatment. New means has never had treatment for TB or has taken anti-TB drugs for less than 1 month. Retreatment means has been treated before with anti-TB drugs for at least 1 month. This includes the following: relapse are patients who were previously treated for TB and declared cured or treatment completed but is presently diagnosed with active TB disease. Treatment after failure are patients who had been previously treated for TB but failed the most recent course based on a positive sputum microscopy follow-up at 5 months or later, or a clinically diagnosed TB patient who does not show clinical improvement anytime during treatment. Treatment after loss to follow-up are patients previously treated for TB but did not complete treatment and lost to follow-up for at least 2 months in the most recent course. Previous treatment outcome unknown are patients who were previously treated for TB but whose outcome in the most recent course is unknown. And patients with unknown previous TB treatment history are patients who do not fit any of the categories listed above or previous treatment history is unknown. This group will be considered as previously treated also. Next, please. Treatment adherence interventions include social support such as material support like food, incentives, transportation, psychological support, tracers such as home visit or digital health communication, medication monitoring, and staff education that collectively aims to ensure completion of treatment. Provider-initiated counseling and testing refers to HIV counseling and testing, which is recommended by healthcare providers to people attending health facilities as a standard component of medical care. The Medical Advisory Committee, or MAC, is a case management committee composed of healthcare providers with expertise in managing drug resistant tuberculosis who reviews and approves the cases presented for empiric treatment and provides recommendations on difficult cases. Standardized treatment refers to a treatment regimen that all patients in a defined group or category will receive. The design of the treatment regimens is based on drug resistance surveillance data from the representative population. However, presumptive multiple drug resistant tuberculosis should be confirmed by drug susceptibility testing whenever possible. Next, please. Individualized treatment regimen refers to a treatment regimen that is designed for an individual patient based on previous TB treatment history, individual drug susceptibility testing results, and history of contact with drug resistant tuberculosis patients. Drug susceptibility testing refers to in vitro testing using either phenotypic methods to determine susceptibility or molecular techniques to detect resistance conferring mutations to a medicine. The intensive phase in treatment of tuberculosis in the context of the National Tuberculosis Program refers to the initial part of a standardized regimen, which usually consists of four or more anti TB drugs. Once some of the drugs are discontinued according to the schedule of the standard regimen, it will now be referred to as the continuation phase. Isoniazid-resistant tuberculosis refers to Mycobacterium tuberculosis strains in which resistance to isoniazid and susceptibility to rifampicin has been confirmed in vitro. Polyresistance refers to resistance to more than one first-line anti-TB drug other than isoniazid and rifampicin together. Rifampicin resistant refers to MTB strains that are not susceptible to rifampicin on the basis of drug susceptibility testing and as a result are eligible for treatment with multi-drug resistant tuberculosis regimens. These strains may be resistant to isoniazid, resistant to other first-line TB medicines, or resistant to second-line TB medicines like as with multi-drug resistant tuberculosis, in these guidelines and elsewhere, the multi-drug resistant tuberculosis and rifampicin resistant tuberculosis cases are often grouped together as MDR-TB and RR-TB. Multi-drug resistant TB refers to MTB strains in which resistance to both isoniazid and rifampicin has been confirmed in vitro. The second line TB drug refers to an agent reserved for the treatment of drug-resistant TB. First-line TB drugs refer to the agents used to treat drug-susceptible TB such as ethambutol, isoniazid, pyrazinamide, and rifampicin. Streptomycin is now considered a second-line TB medicine. Next, please. So for the policies included in the journal, all diagnosed drug-susceptible tuberculosis cases shall be provided with appropriate anti-TB treatment within 5 working days from collection of sputum. The standard treatment shall be given based on the results of the expert MTB RIF. If expert MTB RIF test or any other drug susceptibility testing is not done, the history of treatment will be used as basis for the regimen. The treatment response shall be monitored through follow-up smear microscopy and clinical assessment. Next, please. All adverse drug reactions resulting from treatment shall be reported using the official reporting form of the FDA and managed accordingly. All TB patients aged 15 years old and above shall be offered provider-initiated HIV counseling and testing according to the phased implementation of the TB-HIV collaboration. And all TB patients aged 25 years old and above shall additionally be screened for diabetes. So for the procedures, first, during initiation of treatment, we should inform the patient that they have TB disease, and the duration of treatment is 6 months for drug-susceptible TB, 12 months for severe drug-susceptible extrapulmonary tuberculosis, and 9 to 20 months for drug-resistant tuberculosis cases. We should determine the baseline weight and record baseline clinical findings, such as the TB signs and symptoms, and the weight is we get the weight because the dosage is based on the weight. And we will assign the appropriate drug susceptible TB regimen based on results of the drug susceptibility testing with expert or if not available based on history of treatment. Next, please. So this is the treatment regimens for drug susceptible tuberculosis. So for regimen 1, which is 2-HRZE for HR, which is the usual regimen, this is used for pulmonary tuberculosis or extrapulmonary tuberculosis except TB of the CNS, bones and joints, whether new or retreatment with final expert result of the following. MTB, rifampicin sensitive, MTB, RIF indeterminate, new pulmonary tuberculosis or new extrapulmonary tuberculosis except TB of the CNS bones and joints with a positive sputum microscopy and tuberculosis, loop-mediated isothermal amplification are clinically diagnosed, or if the expert was not done, or if the expert result is MTB not detected. And then regimen 2, which is 2 months of the combination of drugs of isoniazid, rifampicin, pyrazinamide, and ethambutol, and 10 months for continuation phase of the isoniazid, rifampicin. This is we usually see this being used in the extrapulmonary tuberculosis of CNS bones and joints, whether new or retreatment, with final expert result of MTB rifampicin sensitive, MTB rifampicin indeterminate, and new extrapulmonary tuberculosis of the CNS bones joints with positive sputum microscopy TB lamp or clinically diagnosed and expert not done and expert results is MTB not detected. Next, please. So, the dosage is based on weight, and we see here the tables. Um, we give the number of tablets per day for the following weight of dosing for adults and dosing for children. Next, please. So in pediatrics, as what I remember during clerkship, there is a shortcut. We usually just memorize the dosage based on the milligram per kilogram. So for isoniazid, we give 10 milligram per kilogram, rifampicin 15 milligram per kilogram, pyrazinamide 30 milligram per kilogram, and ethambutol 20 milligram per kilogram. This is the regimen for drug susceptible TB dosing for children using single dose formulations. Next, please. Okay, so we will compute for the total drug requirements based on the dosage regimen and 28 calendar days per month. We would allocate and secure the required supply for entire duration of patient's treatment. As what I can remember, usually patients diagnosed with TB, they're already given blister packs, a set of blister packs that they will be taking. And we will also determine other comorbidities and medications and would adjust the regimen if needed based on presence of any comorbidity or any possible drug-drug interaction. If not a known diabetic, we should screen all tuberculosis patients more than or equal to 25 years old for diabetes using a fasting or random plasma blood glucose test with a cutoff level of more than or equal to 7 millimoles per liter or 126 milligrams per deciliter for fasting and 11.1 millimoles per liter or 200 milligram per deciliter for random. If the health facility staff are already trained in the TB HIV collaboration, we should offer provider initiated HIV counseling and testing to all TB patients aged 15 years old and above. Next, please. So, for the approach to TB patients initiated treated by a provider outside a DOTS facility, first, for recording, we should record the patient in Form 1, presumptive TB master list if not previously encoded. We will do expert sputum microscopy, and if not yet done or done by a non-NTP recognized tuberculosis microscopy unit, we will need to record in Form 3A laboratory register for expert, and we would assign the appropriate treatment regimen if decision to treat or continue treatment was made. And we would complete Form 4B or the drug susceptible TB treatment card and register in Form 6A if not yet done by the referring provider. And we should provide feedback to the previous attending physician or facility of the patient. For TB treatment and HIV co-infection, antiretroviral treatment should be started in all tuberculosis patients living with HIV, regardless of CD4 cell count. The TB treatment should be initiated first, followed by the antiretroviral treatment as soon as possible within the first 8 weeks of treatment. If with profound immunosuppression, such as with CD4 counts less than 50 cells per cubic millimeter, HIV positive TB patients should receive antiretroviral therapy within the first 2 weeks of initiating TB treatment. Patients with a TB HIV co-infection should also receive cotrimoxazole as prophylaxis for other infections. And people with HIV infection who, after careful evaluation, do not have active TB should be given TB preventive treatment for presumed latent tuberculosis infection. For monitoring treatment, we should ask the patient to follow up at the health facility 2 weeks after initiation of treatment and then at least monthly thereafter. And we should also perform clinical assessment during follow up visits. The clinical assessment will include getting the weight monthly and adjusting the dosage accordingly, um, asking about the resolution of TB signs and symptoms, and managing any adverse drug reactions or referring if needed, and continuing management of comorbid conditions and to refer if necessary. So, this is the table for managing adverse drug reactions for first line anti TB drugs. So, what is usually encountered here is the orange colored urine caused by rifampicin. And what we should do is to reassure the patient. And then also with isoniazid, it is common to see peripheral neuropathy. And so we usually prescribe isoniazid with pyridoxine 50 to 100 milligram daily for treatment. And we can also give 10 milligrams daily for prevention. And then arthralgia due to hyperuricemia is due to pyrazinamide. And we may give aspirin or NSAIDs. And if persistent, we consider gout and request uric acid determination and managing accordingly or refer. And also, what is usually encountered is impairment of visual acuity and color vision due to optic neuritis caused by ethambutol. And if we encounter this, we should stop ethambutol and refer to an ophthalmologist.
You.
And uh, with and then thrombocytopenia is also encountered. This is due to rifampicin. And when this happens, you should stop
Yeah.
anti-TB drugs and refer to a specialist. Next, please. So after with that, we should request for follow-up sputum microscopy among pulmonary TB patients based on the schedule. For new clinically diagnosed tuberculosis, the first follow-up will be at the end of the intensive phase, which is the second month, and the succeeding follow-up 2 and follow-up 3 will be only done only if positive at the end of intensive phase. This will be the second follow up will be done at the end of the fifth month, and the third follow up will be done at the end of treatment, which is in 6 months. And um, in new bacteriologically confirmed tuberculosis and retreatment, the first follow up will also be done at the end of the intensive phase or the second month, and we will do the next follow up at the fifth month and the next at the end of treatment or the sixth month. Next, please. Then we will decide on the appropriate action based on follow up sputum microscopy results. So we will proceed with treatment if sputum microscopy follow up results are negative. If the sputum microscopy is positive at the end of the intensive phase or the second month, we should request for expert MTB RIF and proceed to continuation phase while awaiting results. If the expert result is RIF resistant, we should shift to a drug resistant tuberculosis regimen. If the expert result is MTB not detected or RIF sensitive or RIF indeterminate, we should just continue the treatment and request for culture and drug susceptibility testing if feasible. And then we should also inform the patient if already cleared for school and work based on non-infectiousness. This is after 1 week of uninterrupted treatment for clinically diagnosed TB cases and after a negative follow-up sputum microscopy for bacteriologically confirmed TB cases. If the patient wishes to return to work sooner, sputum microscopy may be repeated outside of the regular schedule at least 2 weeks after treatment initiation. Next, please. For the management of patients who interrupted treatment, first, we have to make sure that they have regular contact or communication with us every 2 weeks. And for patients who interrupt treatment for less than 1 month, we can just continue the treatment and just prolong it to compensate for missed doses. If the interruption is more than 1 month but less than 2 months, we should perform a sputum microscopy and decide on continuation of treatment based on results. If the interruption is at least 2 months, we will declare that the patient is already lost to follow up, and we should exert all efforts to trace the patient, perform expert MTB RIF test, and refer to a drug resistant tuberculosis treatment center if needed. So this is a table summarizing the management of cases who interrupted treatment. So as what was said, if it is only less than 1 month, we can continue the treatment and prolong to compensate for missed doses. More than 1 month but less than 2 months with a negative sputum microscopy, we can continue treatment and prolong to compensate for missed doses. But if the patient already has a positive sputum microscopy and the patient has been treated for less than 5 months, we can continue treatment and prolong to compensate for missed doses. But if the patient already has a positive sputum microscopy and the patient is already being treated for 5 months or more, we would assign the patient as treatment failed. And if the length of interruption of TB treatment is already more than 2 months, we would assign the patient as lost to follow up. Next, please. So for assigning treatment outcome, this is a table showing the classifications of classifying patients um, for treatment outcomes for drug susceptible tuberculosis. The patient will be declared cured if the patient has been bacteriologically confirmed TB at the beginning of treatment and who was smear or culture negative in the last month of treatment and on at least one previous occasion in the continuation phase. Treatment completed is when a patient who completes treatment without evidence of failure, but with no sputum smear negative results in the last month of treatment and on at least one previous occasion, either because tests were not done or because results are unavailable. This group includes clinically diagnosed patients who completed treatment. Treatment failed is when the patient whose sputum smear or culture is positive at 5 months or later during treatment, or if the patient terminated treatment because of evidence of additional acquired resistance, such as rifampicin resistance on expert at second month, or if a patient for whom follow-up sputum examination was not done and who does not show clinical improvement anytime during treatment. And then died is when a patient who dies for any reason during the course of treatment, and lost to follow-up is when a patient whose treatment was interrupted for at least 2 consecutive months and a patient was diagnosed with active TB but was not started on treatment. And not evaluated is when a patient for whom no treatment outcome is assigned, and this includes patients transferred to another facility for continuation of treatment. But the final outcome was not determined. Next, please. So, for treatment of drug resistant tuberculosis, for drug resistant tuberculosis, the treatment shall be started within 7 days from diagnosis. The monitoring shall be undertaken by clinical, microbiological, through sputum microscopy and culture and laboratory investigation according to recommended schedules and as needed. All severe adverse events and adverse events of special interest shall be recorded and reported through the Pharmacovigilance Information Management System or through the paper form using FDA standard report form for adverse drug reactions. The standard treatment regimens for multi-drug resistant tuberculosis shall be given based on patient eligibility and exclusion criteria. And there are also individualized treatment regimens that will be given to patients who are not eligible for any of the standard regimens. Wait lang, dito lang sa slide na to. So, first, we should do education, counseling, and support to patients and family members prior to treatment. And for pre-treatment evaluation, we should determine other comorbidities and we'll do pre-treatment evaluation including the following baseline tests. A clinical examination including body weight and height, smear microscopy, TB culture, first and second line LPA test, chest x-ray, electrocardiogram, visual acuity and color vision test, um, electrolytes such as potassium, blood urea nitrogen, creatinine, aspartate transaminase, ALT and FBS, a complete blood count, HIV rapid antibody test with written consent, pregnancy test, a thyroid stimulating hormone test, mental health screening, and brief peripheral neuropathy screening. And there are also baseline tests required for specific regimens such as albumin if the regimen contains delamanid from the standard long all oral regimen, fluoroquinolone resistance, and audiometry if the regimen will contain amikacin or streptomycin, which are ototoxic drugs, which are included in the individualized treatment regimen. So for education of the patient with drug-resistant tuberculosis already, we should also provide as necessary the following key messages for TB patients and their families. First is basic information about TB disease covering cause, mode of transmission, clinical signs and symptoms suggestive of TB, and how TB disease is diagnosed and how to prevent TB. We should also inform them that the treatment and drug resistance is not similar to the usual because the duration of treatment in DRTB is 9 to 20 months for multi-drug resistance and rifampicin-resistant tuberculosis cases. We should also inform them the potential adverse events during treatment and the relevance of contact investigation and the tracing mechanism. And we should also inform them that there's availability of free of charge services for tuberculosis and drug resistant tuberculosis diagnosis and treatment. And latent TB treatment for contacts. Next, please. So this is the baseline mental health screening for patients who will undergo the treatment. Next, please. So this is the table showing the types of regimens for multi-drug resistant tuberculosis and rifampicin resistant tuberculosis treatment regimens. Children less than 15 years old diagnosed with multi-drug resistant tuberculosis shall be evaluated for eligibility to standard all oral regimens recommended for children. The standard treatment regimen shall only be offered to patients if all of the drugs in the regimen are available and accessible. Patients who are pregnant and contacts of patients who failed on multi-drug resistant tuberculosis treatment shall be referred to the TB Medical Advisory Committee or TB-MAC for design of an individualized treatment regimen. So for regimen 3, which is the standard short all oral regimen or SSOR, this is given for multi-drug resistant tuberculosis and rifampicin resistant tuberculosis. So for 4 to 6 months, we will give levofloxacin, bedaquiline for 6 months, clofazimine, prothionamide, ethambutol pyrazinamide, and high-dose isoniazid. And for 5 months, levofloxacin, clofazimine, pyrazinamide, and ethambutol. For regimen 4, which is standard long all oral regimen for fluoroquinolone susceptible, this is for patients with multi-drug resistant tuberculosis and rifampicin resistant tuberculosis eligible to the long all oral regimen without any fluoroquinolone resistance. So for 6 months, we will be giving levofloxacin, bedaquiline, linezolid, and clofazimine. And for 12 to 14 months of continuation phase, we would give levofloxacin, linezolid, and clofazimine. Um, and then for the regimen 5, which is standard long all oral regimen for fluoroquinolone resistance, this is also given for multi-drug resistant tuberculosis and rifampicin resistant tuberculosis eligible to the long all oral regimen. And this is given for patients with fluoroquinolone resistance. So for 6 months, we will be giving the linezolid, bedaquiline, delaminid, clofazimine, and cycloserine. And for 12 to 14 months of continuation phase, linezolid, clofazimine, and cycloserine. The individualized treatment regimen is for retreatment of multi-drug resistant tuberculosis and rifampicin resistant tuberculosis cases. These are for patients not eligible to the SSOR or the standard long all oral regimen. For these patients, we will be constructing to have at least 4 to 5 likely effective drugs. And for this, we need to present the case at the TB Medical Advisory Committee and follow their advice for the regimen design. Next, please. Patients who are adults, defined in this guideline, 15 years old or above, not pregnant, and not a contact of a patient who failed multi-drug resistant TB treatment, are eligible to receive standard short all oral regimen if they do not have any of the following exclusion criteria. So, exclusion criteria for standard short all oral regimen. If yes to any of the following exclusion criteria, do not give the SSOR regimen. First, if the patient has disseminated TB or severe intractable extrapulmonary tuberculosis, such as TB of the CNS and bone and joint TB. Second, if there is confirmed resistance to fluoroquinolone. If there is exposure to levofloxacin, moxifloxacin, bedaquiline, clofazimine, prothionamide for more than 1 month, and if there is risk of toxicity or intolerance to any drugs in the SSOR regimen as manifested by history of heart disease, if there the QT interval is more than 500 milliseconds, if there is history of chronic active hepatitis with AST or ALT more than 5 times elevated, and history of chronic renal insufficiency manifested by creatinine clearance of less than 20 ml per minute. Next, please. So if not eligible to regimen 3, we will check the patient's eligibility to the regimen 4 or standard long all oral regimen for fluoroquinolone susceptible. So we cannot give the SLOR FQ susceptible if any of the following is present in the patient. First, if there is confirmed resistance to fluoroquinolone, levofloxacin or moxifloxacin, exposure to levofloxacin, moxifloxacin, bedaquiline, linezolid, or clofazimine for more than 1 month, and if there is risk of toxicity or intolerance to any drugs, and SLOR FUS is manifested by any history of heart disease, QT interval of more than 500 milliseconds, history of chronic active hepatitis, history of chronic renal insufficiency, and severe anemia, manifested by hemoglobin of less than 8 milligrams per deciliter. Next, please. If still not eligible to the SLOR of fluoroquinolone susceptible, we will be checking for the eligibility of the patient to the standard long all oral regimen for fluoroquinolone resistance. Um, so this is the exclusion criteria for SLOR FQR. If we cannot give the patient the regimen if the patient had an exposure to bedaquiline, linezolid, cycloserine, clofazimine, or delamanid for more than 1 month. Risk of toxicity or intolerance to any drugs is manifested by any history of heart disease, QT interval of more than 500 milliseconds, history of chronic active hepatitis and chronic renal insufficiency, and severe anemia of less manifested by hemoglobin of less than 8 milligrams per deciliter. Next, please. So because the medications that will be used for the drug resistant tuberculosis are drugs which are not usually used, we would be performing the following for off-label use of anti-TB drugs. So these situations include the following: the use of bedaquiline and delamanid in combination, the extended use of bedaquiline or delamanid for more than 24 weeks, the use of bedaquiline and delamanid in extrapulmonary tuberculosis, the use of bedaquiline in children less than 6 years old and pregnant patients, and the use of delamanid in children less than 3 years old and pregnant patients. So upon receipt of first and second line drug susceptibility test results of LPA and phenotypic DST test, we will revise the regimen accordingly. Next, please. So this table only shows this is a guide on deciding the appropriate treatment regimen based on the LPA results. Next. Okay, so this table, this algorithm shows the assignment of drug-resistant tuberculosis treatment regimens and revision of the regimen upon receipt of LPA and phenotypic drug susceptibility testing results. So first, once we diagnose the patient as a case of rifampicin-resistant or multi-drug resistant tuberculosis, we would collect 3 sputum specimens for LPA, or what we call as the line probe assay, for sputum microscopy, for TB culture, and drug susceptibility testing. Then we would be checking the patient's eligibility to the short all oral regimen. And then if the patient is eligible, we would be starting the regimen 3. If ineligible, we would check eligibility to the long all oral regimen. And if not eligible, we would be checking for the patient's eligibility to the fluoroquinolone resistance SFLOR. And if still ineligible, we would be consulting the TB Medical Advisory Committee for an individualized treatment regimen. So if ay wait lang, previous pa. Okay. So for checking of the results of the first time and second line LPA and phenotypic drug susceptibility testing, if fluoroquinolone resistance was not detected and high dose isoniazid resistance is not detected, and also prothionamide resistance is not detected, the options to start the patient on are the SSOR, SLOR, and ITR, and we would only continue the initial regimen. If fluoroquinolone resistance is not detected, but with both high-dose isoniazid resistance and prothionamide resistance detected, the options would be to shift the SSOR to a long all-oral regimen fluoroquinolone susceptible. And if the patient is already on the long all-oral regimen and individualized treatment regimen, we would only continue the initial regimen. If on the test results, fluoroquinolone resistance is detected with or without high dose isoniazid resistance detected or prothionamide resistance detected, we would shift the short all oral or long or all oral fluoroquinolone susceptible to fluoroquinolone resistant as fluor. And if the patient is already on the fluoroquinolone resistant regimen, we will just continue that. And if the patient is already on the individualized treatment regimen, we would only review initial regimen and revise if needed. And if the test results show that the MTB is not detected and determinate or invalid, or if there is no available result, we would only continue the initial regimen that we started the patient on if there is culture conversion and clinical improvement. Otherwise, we would need to consult the case with the TB Medical Advisory Committee. Next, please. So for persons living with HIV who are MDR and RRTB, we should start first the TB treatment followed by the antiretroviral therapy as soon as possible within the first 8 weeks of treatment. But if with profound immunosuppression, we should give the patient the antiretroviral therapy within the first 2 weeks of initiating treatment, except for those who are suspected to have TB meningitis, for whom antiretroviral therapy initiation should be deferred due to the risk of developing potentially fatal immune reconstitution inflammatory syndrome. If co-administration of bedaquiline and antiretroviral drugs will be done, we would need to replace efavirenz with nevirapine if still susceptible, because efavirenz decreases bedaquiline blood concentration level by 52%. Next, please. So we need to use bedaquiline with iopinavir, with lopinavir or ritonavir only when other options are not available, because lopinavir ritonavir increases bedaquiline concentration threefold. The better option is to substitute with an integrase inhibitor such as raltegravir or dolutegravir together with dual nucleoside reverse transcriptase. But if the co-administration of bedaquiline and lopinavir ritonavir is really needed, we have to use with extreme caution and closely monitor ECG every 2 weeks. And also, we need to be aware of any potential risk of an additive adverse event when using with linezolid containing treatment regimen. For example, we need to watch out for HIV-related neuropathy when we co-administer linezolid with stavudine, and bone marrow dysfunction, particularly anemia, when we co-administer linezolid with zidovudine. Dolutegravir, which is now becoming widely used globally as a first-line antiretroviral agent, has no significant interactions with bedaquiline, delamanid, or linezolid. Next, please. So for children with MDR-TB and RR-TB, the treatment is usually 9 to 12 months for non-severe disease and 15 to 18 months for severe or extensive disease. So for children with no bacteriologic confirmation at baseline, we can monitor them clinically with watching out for the resolution of TB signs and symptoms, with monthly weight gain and growth, with the baseline chest X-ray and follow-up chest X-ray at 6 months to check the resolution of lesions in case of thoracic TB, and a follow-up CT scan or MRI at 6 months for intrathoracic or extrapulmonary TB diagnosed with these imaging tests, and healing of other extrapulmonary TB lesions such as cold abscesses. For children who have bacteriologic confirmation, we would monitor them clinically as above, with an additional following of the bacteriological monitoring schedule for sputum and culture tests. Next, please. So, in monitoring treatment of patients, for patients who cannot tolerate any of the drugs in the regimen, such as patients who manifest with hearing loss, intolerable pain to amikacin, and persistent vomiting, we need to consider modification of the treatment. We can adjust the SSOR regimen based on results of follow-up sputum microscopy. So, if the smear is negative at the fourth month, we could shift already to the continuation phase. We can discontinue the high dose isoniazid and the proteonamide. If the smear is positive, we can extend the intensive phase for 1 month. If um if the intensive phase extend if intensive phase extended to 5 months and the sputum microscopy is still positive, we could extend more the intensive phase for another month. If negative, we could already shift to the continuation phase. And still, if the intensive is extended to 6 months and the sputum microscopy is still positive, we should already refer to the TB Medical Advisory Committee. And if negative, we can already shift to the continuation phase. And we would be discontinuing bedaquiline at month 6. Next, please. So, if there is no culture conversion for all regimens at month 4 of treatment, or if there is culture reversion, we should again collect a sputum sample from patients and request for diagnostic tests again. And if there is any drug resistance amplification detected from the repeat drug susceptibility tests, we will be declaring the patient as a case of a failure. When the failure is declared or in any other situation when failure is suspected, we should again consult with the TB Medical Advisory Committee for the possible causes, patient management strategy, and registration of outcome. And if the patient finishes their treatment, we would congratulate the patient and instruct to follow up every 6 months for the next year. Next, please. And also, besides monitoring for the treatment outcome of the patient, we would also be monitoring for the reporting of all serious adverse events and adverse events of special interests. This will be reported to the Medical Advisory Committee through the Pharmacovigilance Monitoring System, or PVIMS. So this is a table showing the serious adverse events and adverse events of special interest, which will be reported through the forms. Serious adverse events refers to any untoward medical occurrence that at any dose results in death, is life-threatening, requires inpatient hospitalization, or results in prolongation of existing hospitalization, results in persistent disability or incapacity, is a congenital anomaly or birth defect, or does not immediately result in one of the above outcomes but which require an intervention to prevent a serious outcome. And adverse events, next please, and adverse events of special interest which will be reported. Um, Adverse events of special interest refers to an adverse event documented to have occurred during clinical trials and for which the monitoring program is specifically sensitized to report regardless of its seriousness, severity, or causal relationship to the TB treatment. These are the following: acute kidney injury, hepatitis, hypokalemia, myelosuppression, optic nerve disorder, optic neuritis or retinopathy, ototoxicity, pancreatitis, peripheral neuropathy, and a prolonged QT interval of more than 500 milliseconds, psychiatric disorders, and central nervous system toxicity. Next, please. So for assigning treatment outcome, um, this was actually moderately discussed earlier for treatment outcomes for short course all oral regimen, and for the short course all oral long oral regimen for the individualized treatment regimen. They're actually just the same. The patient will be classified as cure if the patient already has a confirmed bacteriologically confirmed NDR-TB or RR-TB, has completed treatment without evidence of failure, and with 3 or more consecutive cultures taken at least 30 days apart negative after the intensive phase. The patient will be classified as treatment completed If the patient is already without evidence of failure of treatment but no record that the three or more consecutive cultures taken at least 30 days apart are negative after the intensive phase, the patient will be classified as failed if any of the following um, happened. First, if the treatment was terminated or there is a need for permanent regimen change, if there is lack of evidence of at least two negative cultures and not followed by a positive culture by the end of an extended intensive phase of the shorter regimen, or if there's a positive sputum smear confirmed by two consecutive samples after more than 6 months of treatment, if there is culture reversion in the continuation phase after conversion to negative, if there is any evidence of additional acquired resistance to a fluoroquinolone or a second-line injectable drug, and any adverse drug reaction resulting to switching to a new regimen. The patient will be declared as lost to follow up if the patient um, had his or her treatment interrupted for more than 2 consecutive months, and the patient will be classified as not evaluated if a patient for whom no treatment outcomes is assigned. This includes cases who were transferred out to another treatment unit and whose treatment outcome is unknown. Next, please. Okay, next, please. So for post-treatment follow-up, so once the patient has already been classified for treatment, um, we will do post-treatment follow-up at month 6 and 12 after successful completion of treatment. The follow-up procedures will include the following. First, clinical evaluation of TB signs and symptoms, a chest x-ray, and a sputum microscopy and culture. So we will also need to define the outcomes of the post-treatment follow-up. So first, the patient will be classified as a non-relapsing cure if the patient has been successfully treated who remains culture negative within 6 to 12 months post-treatment. The patient will be classified as a case of relapse when there is recurrent TB disease in a successfully treated patient who becomes culture positive within 6 to 12 months after cure or treatment completion, and lost to follow up after treatment completion if the patient had an outcome recorded but cannot be traced in the 12 months following treatment outcome. Next, please.
For the tuberculosis preventive treatment, for the definition of terms, contact investigation, this is identifying people with previously undiagnosed TB among the contacts of an index person with tuberculosis. We can identify the source person as either an adult, child, or candidates for preventive treatment. Household contact, it is a person who shared the same enclosed living space as the index person with TB. Close contact is a person who shared an enclosed space, such as in social gatherings and workplace or facility for extended periods during the day with the index person with TB during the 3 months before commencement of the current treatment episode. In that case of TB, this is initially identified people with TB of any age in a specific household or other comparable setting in which others may have been exposed. Source case, it is a person with infectious TB, usually bacteriologically positive pulmonary tuberculosis, who transmits infection to one or more other individuals. And latent tuberculosis infection, or LTBI, is a state of persistent immune response to stimulation by Mycobacterium tuberculosis antigens with no evidence of clinical manifestations of active TB disease. TB preventive treatment, or TPT, this is the treatment offered to individuals who are at risk of developing active TB disease to reduce that risk. And this is also referred to as LTBI treatment or preventive therapy. So who are eligible for TB preventive treatment? These are the following. Persons living with HIV aged 1 year and older, regardless of history of contact. All household contacts of bacteriologically confirmed TB cases. Children less than 5 years old who are household contacts of clinically diagnosed PTB. Close contacts of DCTB outside the household, and other risk groups such as those patients receiving dialysis, patients who will undergo organ or hematological transplantation, patients receiving anti-tumor necrosis factor treatment, and patients with silicosis. We also have to take note that preventive treatment should not be given to contacts of multiple drug resistant TB or rifampicin resistant TB. The following eligible groups do not require TST. They may be offered TB preventive therapy once active TB is ruled out. So it is important for us to rule out active TB first. Um, Persons living with HIV age 1 year or older, children less than 5 years old who are household contacts of bacteriologically confirmed PTB, and individuals aged 5 years and older with other TB risk factors such as people living with HIV, diabetes, smoking, those with immune suppressive medical conditions, malnourished, and multiple TB cases in same household, and who are household contacts of bacteriologically confirmed PTB. We can perform TSC in the following individuals. However, if TSC is not available, it is not recommended to offer latent TB infection treatment to these individuals. Children less than 5 years old who are household contacts of clinically diagnosed PTB, household contacts of bacteriologically confirmed PTB cases who are 5 years and older but with no other risk factors of TB, close contacts of bacteriologically confirmed PTB, and other factors such as patients receiving dialysis, patients preparing for an organ or hematological transplantation, patients initiating anti-TNF treatment, and patients with silicosis. The following are not eligible for TB preventive treatment. Children aged greater than or equal to 5 years old who are household contacts of clinically diagnosed PTB, household contacts of clinically diagnosed PTB, and children aged less than 1 year old with no contact of a person with TB. It is important to exclude active TB prior to initiating TB preventive treatment. For children with HIV age greater than or equal to 5 years with no symptoms and chest X-ray not suggestive of TB, we can give the patient with preventive treatment unless contraindicated. If the patient has symptoms suggestive of TB, however, upon further investigation finds out it is not TB, we can give preventive treatment unless contraindicated. For children with HIV aged 1 to 4 years, chest X-ray is not required prior to giving preventive treatment. Only symptom screening is needed, and if the patient has no symptoms, give preventive treatment unless contraindicated. However, if the patient has symptoms but upon investigation it is not TB, give preventive treatment unless contraindicated. For HIV negative children aged less than 5 years old with close contacts to PTB patients, chest X-ray is still not required prior to giving preventive treatment. Symptom screening can be done, and if the patient is well or if the patient's symptoms resolved upon follow-up, we can ask if the household contacts are either bacteriologically or clinically diagnosed. If the household contact is bacteriologically confirmed, we can give preventive treatment to the child. If clinically diagnosed household contact, we can perform TST, and if positive, we can give preventive treatment to the child. For HIV negative child contacts age 5 or more years, the screening algorithm for active TB is followed. If patient has no symptoms but tested positive for TST, active TB should be excluded. Chest X-ray should be done, and if it shows no abnormality, patient is treated for latent TB infection. For the initiation of TB preventive treatment, first we have to inform the patient that they are eligible for TB preventive treatment. Second, we have to determine the baseline weight. Third, we can assign the patient the appropriate TB preventive treatment regimen. Fourth, we have to instruct on the proper dosage based on weight. Five, we can perform baseline liver function tests in the following individuals: patients who have history of liver disease with regular use of alcohol, chronic liver disease, HIV infection, age greater than 60 years old, pregnancy, or within 3 months of delivery. However, we should take note that treatment should not be initiated in individuals whose baseline liver transaminases is more than 3 times the upper limit of normal. For the treatment regimens for latent TB infection, the currently available regimen under the program is 6 months of isoniazid. Once available under the program, weekly dosing of isoniazid and rifampicin for 3 months is the regimen of choice, except for pregnant and those less than 2 years old. Alternative regimens subject to availability are isoniazid and rifampicin daily, or for children, and rifampicin daily for adults. Um, Sixth, we can also determine other comorbidities, and we have to take note of other medications that the patient is taking, especially if the patient has diabetes, HIV, and malnutrition. Seventh, if given isoniazid and at risk for peripheral neuropathy, we can give the patient with pyridoxine or vitamin B6, 10 to 25 milligrams per day. If the infant who is taking isoniazid or whose breastfeeding mother is taking isoniazid, we can give supplemental pyridoxine of 5 to 10 milligrams per day. Eight, we can also discuss the appropriate treatment adherence and support mechanism with clients. For the weekly regimen, intake of dose is checked by one, the oriented family member, the community and workplace treatment partner, and healthcare workers. For monitoring treatment of a latent TB infection, we can ask the patient to follow up 2 weeks after initiation of treatment and then at least monthly thereafter. We can perform clinical assessment during the follow-up visit. We also have to get the weight on a monthly basis and adjust the dose accordingly. We can also check for presence of signs and symptoms of TB. If the individual is diagnosed with active TB disease after the appropriate evaluation, we have to stop the TB preventive treatment and start treatment for active TB disease. It is also important that we check for adverse reaction. We can manage any adverse drug reactions and refer if needed, as discussed in the previous slides. If there is a need to discontinue anti-TB drugs due to major ADRs, we do not introduce. In case of a flu-like syndrome due to rifampicin, we can consider a switch to daily rifampicin-containing regimens, or if not possible, isoniazid alone. Drugs can be started at a full dose, but add one drug per day. We also can advise patients to contact their healthcare provider if they become aware of symptoms such as anorexia, nausea, vomiting, abdominal discomfort, persistent fatigue or weakness, dark colored urine, pale stools, or jaundice. If a healthcare provider cannot be consulted at the onset of such symptoms, the patient should stop treatment immediately until they reach care. Number four, we have to perform liver function tests or LFTs monthly for individuals with abnormal baseline test results or adolescents and adults receiving 6-month daily isoniazid or 3-month daily isoniazid plus rifampicin. In addition, liver function tests shall be done at any time during the treatment of individuals who have symptoms suggestive of hepatitis. We have to discontinue treatment if liver transaminases exceed 3 times the upper limit of normal associated with symptoms, or if 5 times the upper limit of normal regardless of symptoms. Fifth, we have to continue management of comorbid conditions and refer if necessary. Sixth, explain the results of any baseline or follow-up tests done, such as liver function tests. Seventh, we have to explain the importance of adherence and completion at each encounter. Any interruptions in treatment should be discussed with the patient and treatment supporter, and interventions to address problems in adherence should be instituted. For interruptions of less than 2 months, we can continue the treatment and prolong it to compensate for the missed dose. Preventive treatment should be reinitiated from the beginning if more than 2 months are missed. 8, we have to record the visit, drug intake, and all findings in the TPT treatment card. For the treatment outcome of patients with TB preventive treatment, patients are classified as completed, lost to follow-up, died, failed, or not evaluated. Completed, patient is classified as completed if the prescribed duration of treatment is completed and remains well or asymptomatic during the entire period. Patient is classified as lost to follow up. This is interrupted TB preventive treatment for 2 consecutive months or more. Patient is classified as died if the patient dies for any reason during the course of therapy. Patient is classified as treatment failed if the patient developed any active TB disease anytime while on TB preventive treatment and not evaluated if the patient was transferred to another health facility with proper referral slip for continuation of TB preventive treatment, if the treatment outcome is not known, or if it was discontinued by physician because the patient cannot tolerate it. Example, if the patient developed a severe ADR or if the patient refused to continue. This is our last slide po. Here are references. Thank you.
Okay, very comprehensive report. So given this pandemic, if you are going to anticipate problems before we go into the nitty-gritty of the changes of your NTP, what will you anticipate? What
Doc,
problems
sorry. Doc, sorry po, yung question po. Ulit. Sorry po.
are you going to anticipate given the scenario of the pandemic as based on your report or your opinion?
Doc, the health-seeking behavior po of patients who may have tuberculosis, pwede pong they won't seek for consult.
So what would that so how would that affect treatment?
Doc,
Men-
if that will be the case po, that patients will not seek consult, the transmission po may be higher since if they're not treated, they will still be infectious po and infect other people and tataas na naman po.
in diagnosis, treatment, etc., etc. More so, your tuberculosis would, although not acute, your tuberculosis would have same manifestations such as COVID, of course, your cough, your fever, etc., which again would deter your health-seeking behavior more, as you have mentioned. Sir? Hindi makapasok
That's see.
si El Rey. Parang lagi siyang, yan na. Okay. Pero hindi tumutuloy eh. Kanina ko pa siya ina-admit.
Huh? Andiyan naman siya. Ito.
Hindi
Ayan na. Hey, Doc.
balik-balik.
Hello.
Hi, Doc.
Na-DBC.
Yes na.
Na-DBC po ako. Sorry.
Okay.
Hi. Good afternoon, everyone.
Good
Good
afternoon po,
Uh,
Doc.
Hi. Good
It's a
afternoon.
good thing Dr. Navarro is there because he would like to get his perspective on tuberculosis in the workplace. No?
Yes.
It's already a burden in terms of public health. No, what
Yep.
can you say about the presentation? It took how many minutes? Almost
1.5 hours.
1.5 hours to go through the very comprehensive. I was
Yes.
following it in the manual, no? But what's your take on that? If you were there, if you were in practice, tapos may TB patient kayo, will you be able to remember all of this? Lahat nitong everything that was mentioned. You can imagine, no? How many algorithms you'll have to follow. Sana meron ng reference. Well, that's the idea there, no? You should have this with you as well, at least for those who are starting clinicians. Para meron kayong guide or better yet, print out the algorithms one by one. More importantly, yung step by step. What are you supposed to when a patient comes to you? What's the next step? No, that will guide you on what's the next step. All right. That's why in my practice usually when I start off and we diagnose a patient, punta ko kayo health center. Because follow up of these patients is very important. I actually have one patient. Later kwento ko. Let's ask Dr. Navarro. Doc Navarro, what about tuberculosis in the workplace? Is there any difference in terms of the way they presented it? Of course, that's the entire program in itself. But tuberculosis in the workplace, impact of tuberculosis, for example, uh, employees or workers, no, diagnosed with tuberculosis. Andres, Dr.
Yes.
Day.
Yes. Thank you, Doc. Actually, tuberculosis in the workplace is um is actually in place with in line with our DOLE. No, they have this implementing guidelines that the company should able to adopt their own workplace policy. Now, the policy and the program of tuberculosis is just not on the treatment and also not on the prevention and control. No, some of these policies would actually have different aspects, no? Like for example, the guidelines will also comprise of the preventive strategies, just like to mention the conduct of the tuberculosis advocacy, training, and also education. So TB education will also be facilitated by the management, say for the company doctor or the occupational clinic, and in line also with the HR, no? And also they also have to follow certain guidelines when it comes to the screening, diagnosis, treatment, and referral to the proper healthcare services. So that's one. That's the more on the preventive strategies. How about the medical management? Actually, prior to that, we also have to be clear about the pre-employment. What would be considered to be patients who need to be screened, no? Kasi part of the screening na to eh. In fact, this is annual physical examinations is also be included. So, in the pre-screening itself, nagkakaroon na ng case finding, no? Especially if the industry is actually have a prone to develop such disease, no? So the screening, the diagnosis, and the treatment is in part with the occupational health services of that company, and that company should also have established certain criteria or guidelines based on what the DOLE or based on the our national TV program is actually been implementing, no? So if the company should say able to detect such, they will just to follow, no, the algorithm itself, and the doctor should also have a bit of a knowledge and training on the national TV program. So the medical management will also have the company should also have to adapt the DOTS that strategy in the management of the workers and also the TB case holding and reporting and recording as well. Remember, this is a public health concern or issue, so this has to be reported. What about also the aspect of discrimination? So that is where the social policy would actually set in. No, there should be non-discriminatory policies and practices. So workers are also protected by such law when it comes to medical confidentiality and data privacy, and there should be no discrimination. The company should still able to provide support and continue employment, regardless if the patient turned to be positive. But, however, what should be the clear guidelines when it comes to the compensation? No, the compensation should also provide access to the SSS and then claims and compensation benefit as well. So this has to be cleared. So in the workplace policy, it is clearly stated there what would be the roles and responsibilities of the employees and also the employer, no? So they need to be aware of such and they need to sign as well, no? That they are subject to pre-annual examination, the case finding and everything, and what would happen if this and that. So the doctor will also have to provide such health education, no? So basically, um, company physicians in occupational health, um, TB program is one of those um, components that should be strengthened, such as along with the hepatitis B, along with HIV. So these are the mandated by the DOLE to have the workplace policies in place with regards to these diseases and illnesses. And um, it is very important these days, especially prior to COVID, no, that it was actually highlighted. Now, what are your workplace diseases policies in place when it comes to, say, for example, patient now have developed COVID, no, patient actually have this and that. So all of these policies should be carefully designed and carefully planned so that would not actually hamper the production, no, especially if it's very crucial. And at the same time, the company's viability and as well the support to our workers. So I think we would also have to strengthen also the awareness, not just on the public but also in the private sector. Kaya they have this partnership as well with our DOH, with our DOLE and on other agencies. And it is the job of this occupational health physician to align also with the regulations and compliances with our government agencies. And if I may also ask Dr. Ray, to our future doctors and our next generation, despite of our advancement to the technology, why do you think tuberculosis remains to be a health problem in this country? And it's been there like for more than 20, 30 years, and the statistics actually doesn't, should I say, improve when it comes to, we already set goals. No, we already part of the strategic planning of the DOH and even the WHO. Why do you think this remains to be a high burden health disease in our country?
If you think about it, parang TB is one of the most understood. Parang in several subjects in med school, paulit-ulit,
Paulit-ulit.
tuberculosis,
And it's preventable, and
right?
yet it's preventable and curable, right? So
Yes.
why do you think? Yeah, why do you think? What's your opinion on this as a doctor?
Doc,
Doc, can...
think,
We'll
Ay,
ask.
sige
Sige.
po.
Go ahead, go ahead.
Yes, yes, yes. Go ahead.
Um, Doc, can I answer po? Well, based on my opinion po, tuberculosis is primarily a socio-economic problem po. Associated usually with overcrowding, poor hygiene, or lack of access po to clean or fresh potable water po, and limited access din po to healthcare. So, since in the Philippines po, usually there is a lack po of well-organized healthcare infrastructure po, and for case finding and treatment din po ng tuberculosis po, Doc. So, and usually din po, Doc, kahit may TB dot center po within the community, hindi po lahat ng tao po, Doc, nare-reach po ng facilities or ng healthcare workers.
So you could you say that the Philippines not able to control such preventable illness is a reflection of the kind of the healthcare system we have?
Um, Possible po, Doc, kasi as what I've said po, it's a socio-economic problem na rin po, yung tuberculosis.
What
Would
can,
there be, yeah, yes, ma'am,
sorry sir, tapusin mo muna. Ikaw muna.
yes, and socioeconomic problem. So we also need to address the sanitation, right? I agree. The also the environmental and also the housing and accessibility. But don't you think in a bigger perspective, these are actually the social determinants of health, right? And as a in community medicine, what would be our role in improving all of these factors that contribute to the problem. What should be done in a community level? Since we are in the community,
Doc, I think po more on prevention. So, information dissemination po in the community will be very important po.
You know,
where,
the weird thing about this disease is that every Filipino knows about it,
Yes. And
right? Everyone knows about it. Everyone knows how bad this disease is. Lahat ng tao natatakot magka-TB, and yet, pag nagka-TB, ayaw magpagamot. I mean, honestly, I mean, from maybe, what do you think, behavior wise?
yes,
even
Because this
stigma,
plays an important
even
role.
the health practitioners, what do
yes,
they do? They hide behind, oh, hindi i-treat as TB. Ah, bibigyan ka lang ng
uh,
for 6 months. Why? Because there's a lot of stigma attached to it. Aside from that, what's the recommendation for protective equipment with regards to tuberculosis? If you were gonna read, even
mm,
Dok,
pre-pandemic,
at least N95 mask po.
yes.
Or
So that PPE level 4 and 95 was already existent, not just for your coronavirus. It was already existed for your tuberculosis. But what's the difference? For at least for the health practitioners. O bakit biglang health practitioners ay PPE na ano with
mm,
with the advent of coronavirus, it was already in the recommendation for a disease such as tuberculosis.
right.
Ano pinagkaiba?
What's the difference?
Dok, feel ko po, kasi po, naalala ko po, Dok, nung clerk po, parang ang dami rin pong ayaw magsuot. Kahit po yung mga interns po namin nun, kasi mas di ka raw makakahinga. Tas parang sabi nila,
JR ka, di ba, JR?
opo, Dok, sa JR. Tas po, Dok, kasi yung COVID po, I guess, para pong sobrang deadly niya talaga compared to TB. Para pong hindi po masyadong common na nakakakita agad ng TB na namamatay ng mabilis. Para pong ganun. Para pong sabi nila, pag nagka-TB daw,
Actually,
maggamot na lang
ano,
daw, ganun.
statistics-wise, anong mas marami ng pinatay or prevalence-wise? If you're
During the start of the pandemic, ganyan yung lagi lumalabas sa social media, di ba? Ba't kayo natatakot? Ba't
Yes,
kayo takot na takot kayo sa COVID? Eh, mas marami pa po pinapatay ang
namatay,
influenza every year. Takot na
yes,
takot kayo sa COVID. Mas marami pang namamatay from this and that.
that,
malaria, dengue, yep,
What's the difference? Bakit? Look, okay, sociologically speaking, look at how COVID was presented in media. Nakatakot.
mm,
Look how DOH tuberculosis advertisements or information materials are presented in media. Okay niyan, galing.
Masayaw, Doc.
sayaw-sayaw,
There has to be urgency, and yet sasayawan sino yung artista? Si ano, si
Mitch Valdez,
Mitch Valdez, so, diba? Sasayaw-sayaw
Valdez,
sila. They're trying to put a good picture of tuberculosis at the back of the minds of the people. Oh, okay lang yan, gagaling. I mean,
yeah, what message can be?
mixed messages kasi sinasabi natin, nako, delikado po yan, kailangan masuko
yes,
natin yan, and yet, oh, okay. Why is it so bad to paint TB, in a bad picture on media? Matakot, may matakot is not a good term. That's a term we often use amongst ourselves pag nasa public health ka. Pero that's the essence of what you're trying to do. Kasi to change their behavior, they have to understand how the burden of this illness is and how the threat of this
yes.
illness. Yes,
So,
COVID, umpisang-umpisa pa lang, namatay, doktor. Whistleblower, patay, tinago. Lahat ng tao tuloy,
Nako,
takot. Right?
mm,
But we've been with tuberculosis. That's the point of Dr. Navarro. TB has been with us since ancient times. And yet, how come? Is it only behavior? I don't know behavior now. Well, let's give it the ano pag-iisipin mo. Ang TB kaya may R0 kaya ang tuberculosis, no? Kasi they say for every patient, for every untreated patient, they would infect 10 people. They would infect 10 people for every year of their life until they die. Kaya yung mga mas matlala na TB, less yung na-infect nila. Kasi patay sila agad. 'Di ba? Unlike yung and that's the thing with infectious diseases. That's the thing. If you watch the a Netflix documentary on the pandemic, and they would say there for an infectious agent to be successful, no, it cannot be too virulent. It cannot kill its host. It shouldn't kill its host very easily, like what happened in Sierra Leone, yung Ebola is a very very deadly virus, right? Virus, pero hindi kumalat. Why? Kasi the people who get infected don't get to transmit the disease because they die very soon, unlike a disease which is silent, would stay dormant for several years up until your immune system goes down and all of that. You don't know that all throughout this time the patient is infecting somebody, and that's the hallmark of a successful pathogen. No, it allows the pathogen to replicate, okay, but in the same time allowing it to be transmitted by the host. Kaya yung mga deadly pathogens, although like COVID, it's a deadly pathogen, no? But just imagine how many patients gets infected. What's the R naught of COVID right now? 1.9. So basically, for every person who gets COVID, they get to infect 1 to 2 people before it's detected. No? Kaya it's deadly at the later on, but before it becomes deadly, it has already been transmitted. Kaya kaya unlike for an illness, for a pathogen which kills its host immediately, it doesn't give it time to be transmitted. So it dies out immediately. And that's the goal of the vaccination program, di ba? Right? To limit the transmission. It's not really to cure people, no. Well, to a certain degree, prevent severe illness, but it's to prevent transmission of the illness, and therefore, the illness itself dies down. Tinanong nga ako nung magtataho namin, di ba? Yan ang mga conversation ko sa mga magtataho namin, sa security guard. Yung magtataho namin would ask me, Doc, bakit ba ganyan? Hindi matapos-tapos yung COVID, no? Habang naglalagay siya ng taho. Okay? Kasi alam nyo, as long as naipapasa yan, dadami yan, may papasa. Oo nga, tama, kaya dapat nagmamask tayo. Yung magtataho namin, very diligent in wearing his mask and face shield. And that's one way. And I think doon tayo nagkukulang, especially even among the medical practitioners. Yung sasabi nga ni Dr. Andres, we sugarcoat kasi the illness. How many times? You take note of this when you go into practice for the interns. Nagkaroon na ba kayo have you had an encounter when you ask a patient if naggamot na sila ng TB and they say no? And then when you ask them kung ano na naggamot nila dati, ang sabihin nila, naggamot po ako for 6 months. Pero that's not TB. Yes, Monina, nagkaroon ka na ba ng experience?
Look, meron po isa dati, for some reason, naggamot na siya 6 months, pero di niya raw sure. Parang pong sinabi niya nung una, hindi TB, pero po, tapos biglang nung pinrobe pa po, baka nga TB. Baka
Yun nga
hindi siya sure.
That's it eh. Why? Because the doctor is not, you have to be straightforward. So tell it to your patient as it is, so that they know that they need to take up preventive measures. Ito lang yun, di ba?
Isa pang segue sa sugar coating, ano lang to, out of topic, UTI. Sugar coat as UTI pero STI na. Yun na pala, tulo. Nakadoxysite. Pero ano ang alam ng patient? Ay, UTI lang po. Pero, he got treated for STI.
Mm.
Pero infective siya at the time of treatment. Paano if he will go on with sexual activity? Will go on with
Kaya, kaya ako, I prefer to send my patients to the health center. Kasi yung mga staff sa health center, diretsahan sila because
Diretso.
private,
they
ang daming
know
hilot.
how important it is. Ano po? Ano po?
Ang daming hilot sa private.
Oo, sa private, ang dami
Private,
kasi,
mga
Daming hima.
self-entitled.
ang daming pakiusapan.
Yes.
Ang daming
Self-entitled.
pakiusapan. They will say,
Lalo na,
naku Dok, paano yan? Baka malaman sa trabaho. Yeah.
yes,
Dr. Navarro is
that's
saying.
right.
Oh. When in fact, yung annual physical examination sa work, that's a very good,
Opportunity.
Opportunity, yeah.
opportunity for case finding already.
I have question also sa ating mga health workforce po, no? So we already identified na that there should be some changes. So what are the changes that are needed for our health workforce to improve the TB control in our country? What should be the values that a healthcare professional like us should have in seeing patients with TB?
Compassion.
Ha?
Compassion.
Ano yung mga dapat nating i-develop? Since
And good
behavior ha? Yes, go on.
Doc, and good communication skills po. Like, i-discuss po dun sa patient yung mode of transmission, yung treatment plan po ng maayos. Kasi po yung iba, parang ang hassle daw po kasi i-take everyday. So, para pong yung iba,
Mhm.
parang feeling nila may ma-miss lang ako bukas, okay lang yan. Para pong yung iba po hindi sila ganun ka-aware na kailangan talagang hindi siya napuputol.
Pero how are you going to have an effective communication kung hindi ka
If not knowledgeable po.
Yes, kung hindi ka skilled dito sa sakit na ito, no? Right? So you have to have uh highly skilled, or you are actually competent, no, enough to handle such cases. So you should be highly skilled and competent. Other would be what? Tama yung sinabi mo na compassion. Why? Compassion, binibaby ba tong mga pasyente na may TB, or compassion kasi naawa ka sa kanya dahil paano compassion? In what way?
Doc, wag pong bigyan ng stigma yung patient na baka po, kasi po yung iba feel ko po baka mandiri or something. Yung ayaw po
Okay.
nila
So,
masyadong kausap yung patient or lumapit, ganun.
and also, mind you, most of our TB patients are the breadwinners. Na kapag hindi nagtrabaho to ng ilang buwan, anong kakainin ng pamilya nila? So you also have to consider that, right? So, taalamin mo din on our level, inaalam din namin, so sir, may compensation po kasi ito, meron po silang program ng company. So you also have to know kung ano yung resources na pwedeng tumulong sa pasyente, hindi lang sa pagpapagamot. No? Sa pag-aalalay din, i-refer mo ba ito sa DSWD rin? No? May mga ganong mga aspeto yan. So by that, dapat, being compassionate also, you know how to identify other concerns such as what? Problems on the treatment. Ano yung mga concerns niya during the treatment? The side effects of the drug, di ba? Dapat kasama na yun sa teaching mo ay anticipated na. Kaya hindi tinutuloy kasi natatakot na. Kasi, hindi nasabi ng doktor. So being compassionate is identify also the potential problems that the patient might encounter. Right? Ano pa? Being compassionate, what entails that? Siyempre, aalamin mo din yung family members. No, magki-case finding ka rin. Missy, sino po ba makasama natin sa bahay? So, nagiging family na yung patient mo. Remember, di ba? Lalo na kapag active TB yung nakuha mo. So, dito ka papasok, compassionate ka. Yes, sir.
That might be a contributing factor, especially in private
Yeah.
practice. Because remember, in private practice, unless you're trained, ang concern kasi ng private practitioners is the patient themselves who are consulting. Bakit? Kasi they're the one paying.
Paying.
Why would I treat the other family members, why would I be so concerned with the other family members when my contract is with this patient only? Di ba? Yan ang tinuturo sa atin ng medical practice tsaka ng jurisprudence. Pag nagkaroon kayo ng contact with the patient, what constitutes a doctor-patient relationship? And to which do you have that contract with? Di ba doon sa patient na nagko-consult? If you go beyond the consult of the yung patient na nagko-consult without the patient actually asking, Doc, paano yung family ko? You're already expanding the relationship to other family members, and you might be liable. You might be liable. But that's the thing. That's what Dr. Navarro is saying. When kaya nga ako preferred ko when I diagnose a patient with tuberculosis, no, I really have to bring up the possibility that the family members, ako sinasabi ko, we have to have them all x-rayed. It's a good thing nga, x-ray na ngayon, that before in the old manual, the old procedures, tabu ang x-ray. Pag nag-x-ray ka, tatawanan ka ng National TB Program. Mortal sin yung mag-x-ray ka to screen tuberculosis. But it has been proven, well, kasi it's available, no? It's readily available than your sputum microscopy. You don't have to collect sputum. You don't have to have a special area for sputum to collect sputum. Especially when patients are already symptomatic. And if you already have a patient diagnosed with tuberculosis, it would be very easy for you to convince them to have their other family members screened by X-ray. Yeah, it's a welcome change in the protocol, no? So what's your take in private practice? Kasi yun ang common. Especially no mga doctors, oh ano 'yon? Ganyan ganyan. Mukhang meron kang spot sa baga. Ito, inom ka nito ha. Inom ka nito, tapos doon ka kukuha sa diyan ka kumuha sa labas. Okay? Tapos 6 na buwan na 'yan, then tapos yung consult. I've had a lot of patients like that na already consulted for the same thing, treated already, well supposedly, tapos wala namang follow-up from the doctor. I would always ask them, what's the outcome? Ano pong nangyari doon sa paggagamot ninyo? Hindi na ako bumalik. Hindi naman ho sinabi na babalik ako eh. Ang instruction lang, 6 na buwan iinumin. They don't even, why? What's the proper instruction when you're gonna initiate treatment of your TB patient based on the protocol that you presented? Haba, no? Dami, no? You don't really expect everyone to memorize this. What's the step by step? Patient comes to you. What's next? You're thinking it's TB. You're thinking it's TB. Pag hindi pa diagnosed, what do we call them?
Clinically diagnosed.
Yeah, hindi pa nga. Wala pa.
Probable po.
Just came to you. Just came to you. Patient just came to you.
Presumptive.
Presumptive tuberculosis. Dati ang tawag dyan TB symptomatic. Parang sinabi mo ng TB. That's why they had to change it to presumptive. Kasi again, the patient has not been diagnosed. Okay, so what's the next step? We heard the presentation. The reporter should know this kasi they thought this over when they were making the slides. So what's the next step?
Doc, we will examine first the patient po for signs and symptoms, then we can request po for diagnostics like a chest X-ray and gene expert po for to know po for drug susceptibility testing, and other recommended po like the line probe assay po and the linear amplification assay po to
Then the patient will tell you, Doc, bakit po kailangan yun?
Doc, I think
Remember, your step was examine the patient and request for laboratory. Bakit po kailangan yun?
Doc, I think po we should first history taking and determine po if ever the patient has history of exposure po to active patients with TB.
So history taking itself, I have a patient, 19-year-old female at the time that we diagnosed her, came in for swelling here sa may base ng sternocleidomastoid. came in for swelling, I referred the patient to Dr. Balmores, pero ni-refer niya rin kay Dr. Chito Cruz. Kasi when the X-ray was shown negative on X-ray, so we had to be sure. True enough, it was tuberculosis. So how long ang treatment nun? Or how do you categorize? Also, na history na, and I know the history of the family. The father has tuberculosis, and the other sister was actually my patient also, had pulmonary tuberculosis. No, but that time, kasi magkasunod silang nag-consult, but at that time, that was the only time that I found out that they actually, kaya when the other sister came by, kasi sabi nga namin, screen na eh, no? When the other sister came by, with that lymph node, what did I tell the father? You know, given their family history, there's a high chance that's tuberculosis. Diretsahan, di ba? And so we have to have it biopsy. Pinabiopsy namin, diretso eh. We also had sputum examination, negative. Would you expect positive sputum gene expert? Negative gene expert, yeah. Okay, so you do your history, do your physical examination, and then you talk it out with your patient. You discuss it with your patient, right? So that when you tell them about the workup that they need to do, they understand why the need to undergo all of this workup. What else? Ano pa? So what's the next step? 19-year-old female. Let's follow the ano. Can you show the ano? Can you show the algorithm? It's a good thing they came up with an algorithm. You might want to have it with you. It's very ano, handy, no, to have the algorithm. Is it different from for the workplace, Doc Elray? Pareho
Hindi
naman
po,
yan.
sir. Pareho,
Pareho.
sir. Opo. Ina-adapt nila yan as is.
We have the algorithm. Kasi para it's nice that we went through the manual, but it's another thing when you're already there. What's the next step? I actually had a computer program of the old obsolete na yung program na yun, of the old protocol done as a project or as a thesis of some LaSalle IT students. So we made it as a project. Nakapasa naman sila with the project. And well, I guess obsolete na kasi nag-iba na yung protocol for that. So what's the next step? Oh, we have all of this. So it's a matter of what will we do now? Even if you have that in front of you, parang exam lang, di ba? I have this experience with my undergrads, open book. So the question was given, and it's an application question. And the open book, I was looking at the student answering. The answer was already right in front of him and didn't know that that was the answer. Kasi nga, hindi mo binasa yung libro. But even this is very extensive. It would be very confusing already where to look for it. Okay, nasaan na tayo? Can you describe to us what happened? Can we show the algorithm first and then we can go into the detail? Yeah. So this is less than 15 years old. So I guess that's the wrong algorithm. Pero dapat ano yan eh. Pero di ba ano yan? Integrated na yung algorithm niya. They have this very big algorithm. But let's go 19-year-old. So who would like to algorithm muna tayo, then you go to the detail. So that you know the flow, no? Kasi pictures would tend to be a lot easier to remember. Okay, nandito yun sa box na to. Okay, so where's the algorithm for a 19-year-old extrapulmonary, because we'll categorize this as an extrapulmonary tuberculosis. Then you see the general algorithm, so we know where we are in the algorithm. Yeah, application na tayo nung ni-report ninyo. Wait, where is it? Nasaan na? I'll look for it on my do I have it here? Where is it? Where is the copy? Not ito.
Dok, wala po kaming algorithm nung extrapulmonary TB.
Hindi,
Pero,
yung general
it's...
algorithm. Where do we start off? Figure 1. Figure 1 on the manual. Can you go up? Do you have that figure 1 on your manual? What's the reference for this?
Yung sa National Tuberculosis Control Program po ng DOH po.
Which manual?
Yung 6th edition po.
6th edition. That's figure 1 on the 6th edition. Nailagay niyo ba? O yun, so dun lang tayo. Let's start off there kasi para we have an idea. Okay, what's the next step? So I have a patient right in front of me with this and this and this and these symptoms. Okay? Kita niyo na? Tignan mo. Bakit hindi siya sa PDF viewer ko nag-open? Kita niyo na?
Ito po, Doc.
Asan ka na? O yan. Ayan ha. O sige, let's go through it. O patient comes in, cough, unexplained fever, unexplained weight loss. Wala siya nun. O nasa na tayo ngayon? O siguro let's start off with the patient with this, no? So cough, patient, mamaya na yung isang pasyente. Patient with cough, I actually prepared a slide for that. So let's say 35-year-old garbage collector consults at the center for history of 3 weeks cough. Okay, but patient does not note any weight loss or other symptoms. Where are we?
Presumptive TB pa din po, Doc.
Okay, game. What's next? After you do your physical examination, nakausap niyo na yung pasyente about tuberculosis, possible that this is possibly tuberculosis. What's the next step for you to do?
Expert.
You do your... What's the next step?
Screening po. Expert.
Yeah, so, tell us. You tell us now. What's the next thing that you're gonna do?
Expert MTB reference.
Expert? Shouldn't you do an X-ray first? Kasi that's more accessible, right? And if you show a patient an X-ray with tuberculosis, and that's very important, you know how to read an X-ray, ha? May tuturo niya sa, ito ho yung TB na sinasabi dyan. It would be easier for you to convince your patient to undergo the next one, right? Right? So,
yes,
you have a chest X-ray, or if they already have a chest X-ray, well and good, then sabihin nyo, possible po na tuberculosis, then what's the next step?
Expert po.
So you do your gene expert. Paano kung hindi available yung gene expert? Paano kung sabihin nila na, ano po, hindi pa po ako makakagawa ng gene expert?
Sputum microscopy.
Culture.
Your
DSSM.
sputum microscopy. So, sputum microscopy. Ano ba yung gold standard ng tuberculosis diagnosis natin?
Culture po.
Yes.
Culture po.
Your
Culture.
na ba? Paano kung hindi magawa yung culture? Wala na. What's the gold standard? Meron ba? Okay, sabihin natin there's no gene expert in your area. What's the next step? What's your alternative?
Dok, pwede kaya pong sabihin po sa patient na yung parang ano po, gumawa po ng request for expert pero po gawin niya sa ibang institution na may
Okay.
expert.
The reason why we're doing this exercise is for us to understand how to go about using your manual. Can you go down? Can you don't go down the screen? Huwag tayong manghula kasi pag nanghula tayo, we're not following the manual already. Okay? So what's our next step kung wala tayong gene expert? Or what's an alternative kung wala tayong gene expert?
DSSM po.
Well, you can still do your DSSM. No? You can still do your DSSM. Okay, so yes to any of the criteria and or suggestive of the TB collect one sputum. Request expert MTB SM when not available. Ayun, nakalagay na dun. Di ba? You can do your sputum microscopy if not available. Now, the problem with your sputum microscopy kasi hindi pa rin na-accredit ng TB program. Well, up until recently, I'm not sure. Yung mga private na hindi nagpapa-accredit. Kasi this is available even in any laboratory. Kaya to gawin ng mga medtech, but they have to be accredited by the program. Hindi pwede magpapagawa na lang sila kahit saan tapos papakita. Of course, if they're gonna bring it to you, you would accept it. Right? You would accept it kasi private practitioner. But in the program itself, they have to be accredited. Okay? So what's the next step? Gumawa siya the patient was able to do the gene expert or positive sputum microscopy. Pero paano kung negative pala both? Paano kung negative sputum microscopy tsaka gene expert? And how long will it take?
Decision po ng physician if i-consider niya po yung patient as TB case po or hindi. And then if the patient is considered as a TB case, he or she will be classified as clinically diagnosed TB.
What if there is a lag between the time of the consult and when the patient will be able to do your laboratory? Are you just supposed to wait? O sige, pag napagawa nyo na ho, balik kayo sa akin. Pero meron ka ng x-ray. You already have an x-ray showing infiltrates.
Doc, we can start empiric therapy po muna until waiting for the laboratory results.
Okay, very good. What kind of treatment? With what kind of drugs?
Yung treatment po for pneumonia since respiratory disease po ito. So possible po na we can suspect first pneumonia until TB is proven na po.
Okay, so what are your treatment options for pneumonia? Ibang pasyente nga, you would be surprised. Allergy lang pala yung 3 weeks cough nila. Especially if you don't see anything on x-ray. Right? So what are your treatment options? O punta naman kayo ngayon sa pneumonia guidelines. Right? But more importantly, avoid your drugs which can be used as second-line drugs. Ano yung paulit-ulit na binabanggit?
Dok, yung mga fluoroquinolones po.
Fluoroquinolones. Okay, you can give your antibiotics for pneumonia, but except your fluoroquinolones, which you might need to use as a second-line anti-TB drug. Okay, so yun lang yung papaalala sa atin ng mga pulmonologist. Okay, so what's next? Dumating na yung inyong laboratory, sputum microscopy, or your gene expert. How would you now label your patient? How would now label your patient? Ano oras na ba? Lapit na tayo. Sige, tapusin naman natin ito. Dr. Navarro, meron kayong idadagdag. Just want to go through the protocol so they more or less have an idea what they're going to do when they're in the clinics.
Go ahead, sir. Okay lang po.
Okay, so what's the next step? Ano na sila ngayon once you diagnose your patient?
Bacteriologically
at least. They are now bacteriologically confirmed. Okay, so what's the next step?
Susceptibility po, Doc, sa drugs.
Of course, in the back, while all of this is happening, you're investigating the other family members then. Huh? You just can't overstress that. Okay, so what's the next step?
Classify, Doc, the patient according to susceptibility po to the drugs.
Susceptibility to the drugs. Okay, and then?
And then, once na-classify na po, we could request muna po for baseline tests.
Like what?
Like hepatic
Okay, o
transaminases.
sige, let's assume all of those have been checked already. O sige, kasi we have to explain, yun po mga gamot kasi has an effect on the liver. Okay, you have to do your audiometry kasi baka meron. Although, can you actually expect in community you'll have to do audiometry first before you can proceed with treatment? Very unlikely, no? Very unlikely. Just make sure that your physical examination will determine your even on history if the patient had any pre-existing ear problems, no? When you're in community. Okay, so what's the next step? Sige, treatment. So how do we treat?
Doc, if the patient po is...
Can you show us kung nasaan? Para aware lahat. Para
Sige.
aware lahat na, ito na pala yun. Dito ko hahanapin yun. Kasi since this is quite an extensive manual, it would be helpful if you have it with you and you know where to look for it. Parang IMCI lang, di ba? Everything is there, but it's a matter of knowing where to look for it. That's why we allowed you to finish everything so we can see if you were able to put it right, to put it there. Okay.
So, Doc, if pulmonary TB or extrapulmonary
What's
TB.
DSTB?
Ano po, Doc?
What's DSTB?
Drug susceptible.
Okay. All right.
Ano po,
Sige. What would you give this patient?
Doc, if the patient po has pulmonary TB or extrapulmonary, excluding the CNS bones and joints, the regimen po would be 2 months of isoniazid, rifampicin, pyrazinamide, ethambutol, and 4 months po of isoniazid, rifampicin.
Okay, how will you explain that to the patient?
Doc, if fix those combination po, iinumin po isang beses sa isang araw ng 2 buwan. Doc, naalala ko po kasi may parang blister something. Yung para pong set na blister pack.
We already have fixed those combination, and that's the reason why I always refer my patient to the health center kasi it's free sa health center. If not, they'll have to buy it outside. No? That's why I refer it to the health center. Para naman monitor din sila ng health center. We actually have a network already for tuberculosis. Online, pwede ka na mag-register ng pasyente mo so that DOH can see them and can communicate with the LGU if necessary. Well, that's the purpose there. No? So, let's say treatment. Okay, how will you explain the treatment? Inom po kayo nito, ha? Pakinggan nyo ako.
Okay, Doc. Pero Doc, based po on weight, so parang
sige, wait.
tablet po.
Sige, let's say the patient is 60 kilograms.
So, Doc, doon po sa table, kung 55 to 70 kilos po.
Nasaan? Can you show everybody?
Wait lang po.
Para sa clerks, para naniniwala sila sa atin.
So, Doc, since the patient po, 60 kilos, so 4 tablets po per day sa intensive phase, then 4 tablets din po sa continuation phase.
Dami yun, ha? Okay. And how will you explain that to your patient?
Paano pag-inom?
Hindi. Paano pag-inom, tsaka bakit may dalawa? Bakit meron pang 4 ngayon, tapos 4 uli mamaya?
4 uli.
Ano yun? Bakit hindi na lang, sige po, 4 para ho sa 6 na buwan?
Doc, yung sa ano po, HRZE, kasi po yung Yung pyrazinamide ethambutol po, tina-target po yung dormant tsaka intracellular.
Well, you can't explain that to the patient that way. How will you explain the patient now? Inom ho kayo ito ha. Ito ho yung, kasi ho, dalawang klase po ang gamot. Yung isa apat ang laman, yung isa ho dalawa lang. Okay? And how will you explain that? Kasi, yung importante ho, sa ngayon, yung 2 buwan ho na gamutan. Ito ho yung matapang. Use the vernacular that they're, ito po yung matapang, kaya dapat maiinom ho ninyo yan. 6 na buwan, 2 buwan po yan. Then after ho nun, magpapalit tayo ng gamot. Provided natapos niya yung complete. Ilang araw lahat? How many days is the complete 2 months? In terms of days?
Ano po, Doc? 60 days po.
Oh, nakasulat doon kanina. Binasa ninyo. How much is the complete 2 months in the TB program? Paano kung 31 days? E di 61 days. Paano kung 28 days lang yung February? E di 28 days lang. So how much is a
Doc,
month?
28 calendar days po.
28 calendar days. So hindi nila susundin yung what's in the calendar. They have to follow 28 days, which is equal to 1 month. So therefore, 2 months would be equivalent to 56 days. 56 days. Okay, so in 56 days, how many tablets should they have taken? O yan, part yan ng trabaho natin. Kaya ako pag nagpe-prescribe ng TB drugs, ang tagal. O computein mo pa isa-isa. O compute 56 days times ilan ba yun? Times 4 yung pasyente. O para hindi sila nagugulat, Dok, 200 plus na tableta. Oh, kasi 4 tablets a day po kayo. Why is it very important to distinguish between the intensive phase and the continuation phase? Because most of these patients, natapos ko na yung 2 months, 6 months to, tutuloy ko na lang. Right? Tutuloy ko na lang. Why do you need to stress that they have to come back after 2 months?
Doc, to check po for
or before the end of 2 months. Oh.
To check po for conversion po sa sputum.
So one, you have to do a retest and find if they're if they're sputum negative already. Right? Kasi kung hindi ka sputum negative before the end of the 2nd month, what's the next step? You have to
extend po for another
month. Okay? And then, what's next? Sabihin natin the patient was able to complete the initial 56 days. And the patient will ask you, ba't kailangan ko pong bumalik sa inyo?
Para po ma-check po natin kung gumana po ba sa inyo yung gamot.
Okay. What else? What
Check
else?
din may adverse drug reaction.
Okay, adverse drug reactions. Of course, sasabihin mo na, pag may reaction po, pag may nangyari, may ramdaman kayo, kontakin nyo agad yung clinic. O what else? Or punta ka agad kayo sa center namin. What else?
Symptom resolution po.
Okay, symptom resolution, very importantly, especially if the patient has weight loss. So what's now the significance of coming back for the continuation phase? Especially for patients with very poor stature, their stature will improve, their health will improve 2 months. Gaganda sila. I've seen that happen in patients. Kayo, Dr. Navarro, may nakita ba yun? Yung gumanda yung katawan, no? And that will entail weight gain. And that will entail weight gain if they don't come back to you for the continuation phase and nag-gain sila ng weight from 65, sabihin natin nag-70 kilos, you have to adjust the number of tablets to cope with their weight gain. So hindi nila pwedeng ituloy lang yon for the next 4 months. Ito yung binigay sa akin. Ito, kasi if they gain, and it happened in one of my patients, rather young patient, 21-year-old female, nag-gain siya ng weight. So we had to adjust now. That's the thing. When they gain weight, you have to adjust the treatment. Kaya to a certain degree, yes, more convenient yung ibigay nyo na sa kanila yung buong 6 course. But what if they gain weight and then your previous to test for everything? And of course, you have to reevaluate your patient. If they gained weight, then you have to step up the number of tablets. So kung nag-70 siya, okay, dahil magana na siyang kumain, less na yung burden ng disease sa kanya, no, better countenance, okay, improved countenance, then you have to adjust based on the patient's new weight. Okay? And that yung means, I think that oftentimes that's another thing that is overlooked. Especially for children, ang bilis mag-gain ng weight ng mga bata. Okay? And you have to adjust it accordingly as well. Okay, so naggamot na, patapos na yung 4 months continuation phase. Okay, and we have to explain also why the continuation phase is important. Because the initial intensive phase won't be able to get everything, right? So we have to parang clean up for the succeeding 4 months, the remaining 4 months, succeeding 4 months. Okay, and what are you supposed to do before the 4 months is up?
Retest po ulit, Doc.
You have to retest again if the patient remains negative. Right? If the patient remains negative. Pag negative siya, kasi that's why you go to the criteria. You go to the criteria for outcome. For outcome. I'm trying to make sense. Patapos na to. Go to the page for the outcome. Pag bata, magko-compute. Yes. Very good. Relating earlier yung naalala natin. Okay, of course, you have to be familiar with the side effects and all of that. Okay. Oh, so yan. How will you kasi when you commit to treat a patient, you also have to declare them. They have to declare their outcome. May form actually yun. May form siya. And that form can be given by the patient to, let's say, another doctor at the health center, no? If they happen to consult again. So how can we say that the patient is cured? A patient with bacteriological confirmed at the beginning, so we did that, who was smear or culture negative in the last month of treatment, and yun ha, on at least one previous occasion in the continuation phase. So dapat meron kang intervening test. Kaya nga ginawa mo di ba yung sa intensive phase before you go into the continuation phase. Okay? Meron kang intervening test. Dapat dalawa. Okay? All right. Pag wala kang nagawa, let's say then that's the usual case. When the patient would come to you, hindi na nakapagpagawa ng tests afterwards. Although they had one, ayan yung sabi na dyan, negative results in the last month of treatment on at least one previous occasion, either because they tests were not done or because results are unavailable. So pag wala ka nung result, okay, completed lang siya. Kasi there's no guarantee that there's cure. Pero you can guarantee that the treatment was completed. But then again, in the private setting, this is very difficult kasi you don't monitor your patients. Right? You don't see your patients take, unlike if the patient is referred to the TB dose. Okay? And then you have your treatment failure. Of course, obviously, if the patient still remains positive, at 5 months or later, then that would be treatment failure. And what do you do with treatment failure patients? Refer na natin sa PMDT, no? Programmatic management of tuberculosis patients. Okay? Or died, or lost to follow-up. Very important yung lost to follow-up. What's lost to follow-up? Treatment was interrupted for at least 2 months. If the treatment was interrupted for less than a month, what are you supposed to? The doc, tumawag siya, Doc, nakalimutan ko uminom ng 3 araw kasi may biyahe ako eh. Anong gagawin ko? What are you supposed to advise the patient?
Dok, pwede pong ituloy lang.
So that means yung 56 days niya in total will be the number of days that he missed. Right? So meaning 59 days na siya. That's you have to complete what was missed, but of course you have to reinforce to the patient hindi mo maganda yung nami-miss out niyo yung gamot. Right? Okay? So When do we declare them as okay, fit for back to work or fit to Dr. Navarro?
Yes,
Yeah, that's
when
a very common concern, Doc.
yes,
Halimbawa, kung
that's
pwede
right.
pumasok ulit.
Pwede bang bumalik or do I need the pulmo clearance or what are the guidelines, no? We usually we tell our patients that they need to be first treated, no, and classified accordingly. If the patient has an active TB and the patient is actually enrolled in DOT or on the program, we usually tell them that these patients are not infectious anymore within 2 weeks, and they might be actually able to return to work provided that they should present as a document, the documents, supporting document that they have been actively treating and they actually been under the program. And however, if a patient is classified with a multi-drug resistant, it's another case. No, we need to see a proof of conversion with the sputum. No, and at the same time, what are the medications that are being given and referred to the pulmonologist. So basically, it depends on how we classify our patients and what would be the supporting documents that we needed by the company for them to be allowed to go work again. And we normally don't give much of a pressure or stress, especially say I had a patient who was working in a call center, and as you all know, magsasalita yan for 8 to 12 hours, no, non-stop. And most of the call centers are doing the job on the graveyard shift. So mga 11 p.m. yan, up to 6 a.m. in the morning. Kapag may mga patients kami na ganito, we normally put them in a light work or like say morning shift or hindi gaano stressful para sa kanila because of giving some sort of a consideration. And again, these are protected by the company guidelines and policies. And of course, it is arranged again with the HR or the management. Yun po, sir. Yung mga
Mm.
madalas na na-encounter natin yan sa mga call center.
Mm-hmm. Kasi sa akin, usually, does it have to be a pulmonologist?
Hindi
Pagka,
naman. Hindi
um,
naman, sir. May mga ano naman po, sir, minsan na kahit sa IM, no, not necessarily pulmo clearance naman din yung iba.
mm-mm.
Unless
Pero,
may mga underlying problems pa siya.
mm-mm. Pero in practice, Doc, nasusunod ba yung 2 weeks? Na,
Ah,
kasi we tell the patient, pag 2 weeks ho, hindi na kayo nakakahawa. That's the basis for
oo.
the 2 weeks eh. As long as they complete the 2 weeks straight, hindi yung 2 weeks na may skip. 2 weeks na straight, we would tell our patients, you're no longer infectious. That's the basis for allowing them to go back to work or go back to school in 2 weeks. Pero in
Normally, sir,
practice,
nag-extend pa sila ng isang linggo or binubuo na nila yung isang buwan kasi may sick leave pa naman. So parang, sige,
ah,
so kinukonsume na nila minsan, sir, para o sige, isang buwan, tapos balik ka na lang. Minsan tinatawagan na
ah,
sila or tatawag muna sila prior to, kasi naka-mark na po yun, sir, na okay,
yung pala
magpapagamot
yung
muna
basis,
siya.
no?
Opo.
Oo,
At
alright.
saka, mind you, pag nakukonsume nila kasi yung mga sick leave and all, paid yun eh. Diba? So,
Mm.
na-enjoy pa nila minsan yung
So
sick
might
leave
as well
talaga.
take it up, no? While there's a
Yes,
valid reason
yes sir.
to do
Lalo
it.
na
So,
lalo na kung talagang close contact sila sa mga workers niya, call center siya. So talagang makita mo may talagang possibility na kumakala. At saka minsan pagka nakaka-identify sir ng pasyente na ganito, parang talagang nagme-memo na sa department
mm-mm.
na may index patient tayo and we need to have this. And pinababalik yung mga pasyente sa clinic. Tapos
Mm-mm.
nire-review uli yung mga medical records nila.
Mm-mm.
And mind you, some of these call center agents are actually very pro, no? Mga high risk to. Mga 40 to 50 years old na smoker, na medyo puyat lagi, stressful. So talagang makita natin na these people are actually on the high risk level.
Alright.
Uh,
Okay, thank you, Doc. So, nakatapos na tayo ng treatment, na-declare na kayo. What's the last thing any other things that you would tell your patient?
Post-treatment follow-up po.
Okay, anong purpose ng post-treatment pala?
Dok, kung bumalik po siya, kung mag-positive po siya ulit or hindi po.
It's very important to tell our patients, no, hindi po yan parang tigdas na pag nagkaroon ho kayo, hindi na kayo magkakaroon uli. Right? You can still get reinfected or even reactivation of the TB and also your family. No? Kasi may ibang patient kasi nagtatanong, Dok, nagkaroon na ako dati, ba't meron na naman ako? Diba? So we have to inform them that this type of infection, we don't really develop immunity to this type of infection. Okay, and by informing our patients about that, they would hopefully, and of course, remind them about preventive measures. Ano yung TST pala for children? Well, let's just touch on children briefly.
Tuberculin skin test po.
In the private, ano ang tawag doon?
PPD.
PPD, the same. No, pero TST siya sa public health, no? And you have to read it after around 72 hours. 72 hours para maging accurate. Okay? Hindi siya yung pupunta tapos mamaya-maya babasahin mo. And why do we do PPD or why do we do TST for children?
For LTBI po, Dok.
Ano yung LTBI?
Diagnose po latent TB.
Why? Why? Pwede naman natin. Ginagawa rin siya sa adults. Do you agree
Dok,
sa PPD sa adults? Dr.
Doc.
Navarro, habang nandiyan pa si Dr. Navarro, yung PPD,
Yes,
Doc,
sir.
sa pre-employment, kamusta na yun? Kasi
Hindi.
DOH will always tell us, di ba, sabi ng DOH, hindi recommended ang PPD for pre-employment sa Filipinos kasi magpa-positive tayo. But then again, it's still required. Dito ba sa Philippines or is it just abroad?
Sa abroad, tingin ko, sir, abroad.
Sa
Mostly.
abroad?
Pero sa DOLE, hindi na po nire-require ang PPD. Hindi
Okay,
na po.
alright. Very good. Kasi mapapansin ka lang yung mga pupunta ng Saudi, di ba? PPD. The chance of a Filipino being positive to PPD is very high. No, because we would have TB infection but not TB disease. We have to differentiate between the two. Okay? So why TST? Why do TST in just wanted to stress, no, yung PPD hindi really advisable. It's not recommended to be done on adults because you can do other tests on adults which are more specific. Okay. Why TST for children? What's the indication for the reason for doing TST in children?
Doc, if I can remember lang po correctly, sa children po, if I'm not mistaken, less than 5 years old po ata. Pag nagka-TB po sila, hindi sila magma-manifest ng signs and symptoms usually. Kaya po,
why would you test the child in the first place if they are not manifesting anything?
Doc, baka minsan po may iba silang symptoms na hindi po typical of TB.
And you can do TST. Why not other tests? Bakit TST? Why TST? Mantaw test, di ba? Mantaw test. Okay? For the interns, pag nag-exam kayo, mantaw test. Why TST? The reason for that is because usually children below 10 years old still don't know how to expectorate properly. Saliva ang nakukuha. So when you do your test, they always come out, they would more often than not come out as negative. Kaya nga what we did actually in Bacoor when after we underwent training, no, ang what DOH instructed us actually was yung mga bata, if you can get the consent of the parents, pa-TST nyo yung mga bata. Actually, we were very successful. Ang daming bata. Free tuberculin skin test. Why? Kasi pag nag-positive sila on TST, what are the chances? How will you use that to improve case finding? You can tell the parents, kanino nyo makukuha? Sa kalaro or sa inyo. And that would be a basis now for asking the patients to get screened or the parents to get screened. So they wanted to do it the other way around. Usually kasi what happens, the patient, the parent is diagnosed for TB, and then you would do TST to the children to screen them for that. And sabi nila, maybe we can do it the other way around. We can do TST, parang mass TST, no, sa mga bata. Of course, you have to get the consent of the parents. Then if they turn out as positive, no, because that's what the story for the X-ray, why the X-ray was included in the protocol. That's one doctor actually did against the protocol during that time, hindi protocol. Okay? So, ang ginawa niya, against protocol, pina-X-ray niya lahat ng constituents nila. Pinilibre nila sa health center. Ang dami nilang nakuhang TB cases. Pinresent niya sa DOH. A couple of years later, it was included now in the ano. I don't know if they actually did, and I'm sure they did further studies on to determine the use of X-ray. Kasi the tendency of most people is to do X-ray, and you would know, see in the clinics, yun ang pinaka-common incident. Well, it would be an incidental finding, X-ray for some other reason, annual PE, and all of that, and then you would see tuberculosis. So why not use that as part of the screening for your patients? It's very fortunate that we can actually do it right now that way. Diba? All right. So I hope we learned something and realized na very extensive ang TB program. It's not something that you would be able to memorize in one sitting, but a very important aspect of your practice, not only if you're going into public health, but more especially also as private practitioners. Any last words po sa Dr. Navarro, Dr. Audrey? Thank you very
Um,
much.
thank you po, sir. So, just guys, you have to remember, no, na we are actually doing all of this in the future that you're going to encounter such dilemma or such patient, and these basically are actually general, no, general knowledge of a, say, a general physicians would actually be well informed about such illness, especially here in the Philippines. And mind you, tuberculosis is actually a big part of your preventive medicine in the board examination. So you need to be very keen and knowledgeable about such health program as this. Okay, so thank you guys, and I also would like to commend the presenter for a very intensive discussion on our national TV program. Keep it up.
Agree.
Thank you po, Doc.
For Tuesday, DOH and PhilHealth as assigned, and community diagnosis in a background of COVID on Thursday. Gusto mo, sir, singit yung MCCOD?
Yeah,
Tuesday.
I have an additional activity. Well, I mentioned this already to the interns. But for hanggang kailan ng clerks natin? We'll take only a few sessions kasi online yung activity. Hanggang
Feb 2 po.
Feb 2. Okay, so we can do it next week, no? So we actually were given the opportunity to take advantage of the online medical certification, hindi, uh, medical certification for cause of death online platform of UP, University of the Philippines. We've been trying, and other institutions have been trying to include the PGIs kasi ang tingin actually ng mga faculty, this would benefit the PGIs more. I underwent the training as a trainer for this one with their intention na this we would teach the PGIs ang kaso na ganito. So the target of the platform was actually for clerks and third years. Kasi ang assumption nila, by the time you go to as PGI, you've undergone yung clerkship na training for this, no? So the reason why I'm bringing this up, we'll still try, pero yung last message kanina sa Viber group namin, pang clerks talaga eh. Sorry PGI. We'll see ha. We'll see pa rin. Are you already trained? Did you undergone seminar on certification of that?
Doc, nung clerk po kasi ako, yung legal med po na rotation, di ko po na-take kasi po dun po nagka-COVID. Kaya po, di pa po ako nakakaano.
Okay. Hindi. I'm trying to come up with our own parallel to what we have in UP. This is for the PGI since we already underwent the training. No? So this one, it's gonna be a Moodle platform for the clerks. So we were told na if you're gonna really sit down on it, mga 4 hours lang tapos. And then we'll have an SGD after you finish the platform for for exercises and for other clarifications. And this would prove very useful, especially when you go to interject. Kaya ang tina-target nila yung clerks eh. But for the interns, I will try to see if I can come up with ano. Do you have a copy already of the latest that certification manual?
None pa po, Doc.
Wala pa. Post ko na lang sa PGI Viber group. So you can
Okay
go
po,
through
Doc.
it. And then maybe we can have one session with you guys para lang ma-orient kayo. Dr. Andres, kasi this was I don't know if there's a request to have this again. I think this is very important. Sabi nga namin, dapat nagpo-focus tayo ngayon at this point sa mga clinicians, sa mga consultants. Kasi kababanggit lang ni Dr. Crisostomo last meeting namin na may problema ang medical record sa death certificate, natatagalan. Dapat consultant ang tinuturuan. At saka residents, di ba? Di ba? But again, this is training. So ang goal ng UP being an academic institution is to teach the students. Okay? So for the interns, I've been given the access pero isasend ko muna yung name ninyo so we can do this next week. Kung hindi man tayo uh, Thursday baka Friday, I have to schedule it pa. Okay? Kasi Dr. Andres, na-submit ko na rin po yung name ninyo for that. So that when we go teach our students this, pare-pareho tayo equal footing on the training. Also, Dr.
Send mo na lang pag meron na.
Apo, I'll send you your link pag meron na kayong account. But I was given the student access already for the clerks. Pero I'll send it to you once. Kasi the reason I have to tell you, kasi I have to send your name to UP. No? Send your name to UP. Ano lang naman siya, go through the online module and then we'll have an SGD to discuss yung natutunan ninyo. Okay, so for the interns, that's something I will try to do as well. If I can make a quote-unquote app similar to that. Because I have a learning platform, di ba? Meron akong LMS. So if I can transfer the same activities there, then we'll use that for the PGIs for more or less meron na kayong background. All right? And I'm not sure kasi ang usapan with with DOH, ipupush nila sa PRC na magkaroon ng questions on death certification. That is the basics of death certification, di ba? Dapat lahat train. Okay? For the third years, actually, nasa curriculum, nasa schedule na nila yun. Alright? So once I expect baka over the weekend, kundi man bukas, baka over the weekend or on Monday, I'll be able to send you your access. I already have the code. I've been given the code for the students. So I'll send it to you. Tapos you give me your feedback on the activity, and that's also the purpose of the SGD. If we can have a faculty from NTT and ano tayo? National Teachers Training
NTTC?
NTTC. NTTC or UPMCCOD with us. Actually, they might be joining us para they can reinforce as well kasi sila yung trainers. We're just facilitating for you to join the program. And hopefully, this will be a standard platform for medical schools, even for interns. I believe the DOH has lied low on their training, so hopefully we can still push that the interns be included in the program. Nag-request na rin si Dr. Crisostomo. They're focusing mostly on the course. Okay? So I'll send a message sa Viber group once we're given your go signal. All right? Okay. Sige. Anything pa po?
Doc,
Yes, Abby.
Question lang po regarding po sa discussion on Tuesday po, sa PhilHealth po na topic namin. Ano po kayong pinaka-i-focus namin, Doc?
UHC na lang yun. Kasi binago ng UHC lahat ng buhay natin. Universal healthcare.
Sige po, Doc.
Yung universal. I have to, let's confer with Dr. Andres.
Sige po.
Tama ba? Dr. Andres, yung PhilHealth and DOH, that's UHC, correct? Tama po ba? UHC. Okay, so present yung ano yung bago with PhilHealth and UHC. So that tama-tama for the interns. Dapat alam nyo na. Kasi by the time you pass your board exam, ito na yung in effect sa inyo. Alright? Okay. O sige po. Anything else? Ang ganda nung lugar ni Dr. Navarro. Saan ba si Dr. Navarro ngayon? Saan ka ba ngayon, Doc?
Uwi na yan.
Uwi ka na ba? Andito ka na?
Nandito na po ako sa condo, sa Makati.
Oo nga. Nakita ko nga. Chilling ka nga sa condo.
Chilling na ako. Malinis ako. Negative PCR. Nag-self-quarantine ako,
Nag-quarantine ka na.
Yes. Okay.
Sige. Kung wala na po, thank you very much. We'll see each other Tuesday for the clerks. I'll send you your invite.
Thank you, guys.
Thank you po.
Thank you. Bye.
Thank you po, Doc.